Megan Fox.
And Megan Fox has the story.
Megan Fox.
Megan Fox.
Megan Fox writes at PJ Media.
Eat Tucker.
And that was your last.
Damn it, man. I cried for 2 days.
Megan, thank you very much for that.
So, I can explain the bed thing.
If you don't show up and vote, up your ass. I don't care if you're in the hospital. Crawl to the stake. Crawl there.
It's like Jesus going into the temple. He's like, I got a whip. Get out! Get out! The lovely and wonderful Megan Fox. Not that one.
Not that one. Not the weird one that drinks blood in his toe thumbs.
Megan Fox.
Megan. And honestly, Megan, if you don't like it, I'm sorry.
She's the devil.
Megan.
Megan Fox.
Megan.
Megan.
Megan Fox.
I've been very nice to you, although I could probably maybe not be based on the way you have treated me, but I wouldn't do that.
You've never met a like me. You want to tangle? You want to go?
Holy sh!
Too much cussing on this. I guess we didn't bleep it, so we got to turn it off. But it's.
You pissed off the wrong woman.
Oh my God! I have been assaulted when Megan Fox runs wild on you, brother.
She's the devil.
Not for publication.
The story.
I'm Megan.
Megan.
Megan Fox. Thank you. Cheers.
Hey everybody, welcome to the program. I'm Megan Fox and I am here. I'm sorry I'm late. I had a bad night last night. I woke up at 2:30 a.m. and I could not go back to sleep. So I laid awake until 6:30. From 2:30 to 6:30. I'm laying awake, wide awake. And then when the kids got on the bus, I got real sleepy and fell asleep. And I pretty much just woke up. So sorry. Anyway, while I was getting ready, and then I decided it was a hair day. I was going to have to do wash day, and that always takes a long time. Because my hair's been just a mess. It's just been a mess. So anyway, I took the time, I did the curls, and while I was getting my hair, doing my hair, I was listening to what's going on in the courtroom. So we are going to skip over a couple of the witnesses this morning because I thought they were really boring and they didn't add anything to the conversation. It's basically, okay, the Dick defense is just what they're doing is they're now putting on a litany of doctors from every hospital that will read through the notes and regurgitate what you've already heard. That's what I heard this morning. My glasses are so dirty. I need some kind of glasses cleaner. All right, anyway. So the first one was she a psychologist? She was from, I can't remember. She looked like Janice the Muppet, though. She's too much plastic surgery and fillers. Anyway, she was boring. Nothing came out of that one. And then the next one was a psychologist at Lurie Chicago Hospital. And basically her entire testimony was, yeah, it's in the notes, but I didn't write it, so I don't know. Really, that's her entire testimony. Yes, it was in the notes, but I didn't write it. I don't know. And I don't know why they didn't call the doctor who wrote the notes, but they didn't. So who we're going to skip to is the expert, because today is the defense's day to bring on their expert on CRPS. And I about just died because what he just said just now on the stand, well, from where I was watching, he said there's no such thing as CRPS lesions. I can't even. I can't even. I mean, unless we are to believe that all the other CRPS experts we've heard from, which would include Dr. Chopra, Dr. Kirkpatrick, Dr. Newberger, who is also a child abuse expert, and who else? Oh, Dr. Hannah. There were other doctors we heard from. Every one of them talked about lesions, skin lesions. This one wants you to believe that there were no lesions, that CRPS patients don't have lesions. What they get is some type of dermatitis. Well, okay, sir, there's all kinds of dermatitis. So anyway, I'm looking it up. I'm like, is this true? So it's called bullous dermatosis associated with complex regional pain syndrome. You guys, these photos, I can't show you. They're too bad. Oh, what just happened on my screen? They're too bad. They're too gory. I'm not going to show you, but believe me, this is a real thing. CRPS lesions are a real thing. Now, maybe they're called something else, for the medical crew, but I was dermatitis by proxy. Anyway, we're going to start with him, and I don't know his name. I forget his name, but he is the defense's expert, and we're going to start there. So let's get over there. The heck am I doing? All right, I don't have it pulled up yet. I'm sorry. I'm running behind. I was making tea. Dr. Elliot Crane. Thank you. Thank you, Nick. It's Dr. Elliot Crane. So we're going to start there because I wasn't impressed with the other, and there was no cross-examination, and the jury had no questions for the other two women. If you want to know what they looked, I'll show you what they looked like. But other than that, I don't think we need to watch them. We're going to just start with Elliot Crane. Actually, silent PS. How do you become an expert in abuse? Things that make you go, No, Dr. Newberger actually was the founder of the child abuse specialty, really. And he disagreed entirely with how it has turned out. His testimony was amazing. He's really, really good and a very compassionate man. So, all right, here were the witnesses today. This one is the one that I thought looked a little bit like a Muppet. Ladies, don't get fillers. Your face starts to look like a monster. And she's cute, but she's way too young to have done all that fillers to her face. Her testimony was not interesting at all. Just not at all. And everybody who gets those fillers ends up looking like Janice from the Muppets. Now, this one was the other doctor. She's a psychologist at Lurie, and she basically, her entire testimony, like I said, was looking at the notes and saying, yes, that's what's written there. And I didn't write it, so I can't tell you. So it was really not, and nobody had any, that was a deposition. And the other one testified by Zoom, and nobody had any questions. The jury didn't have any questions. Anderson didn't have any questions. He passed because there was nothing in it. There was nothing in it. Okay. And well, hey, Rumble, how you doing? I'm on Rumble. Good to see you over there. Let me get my Rumble page open so I can see your chat. There we go. Let me close out these other windows because this is going to screw with my StreamYard, I'm sure. Yeah, that tie is an interesting choice. I don't know if I like it or not. I love that color, turquoise. That's my favorite color. Yes, now, okay, these are experts, or this guy is an expert. And so that means he didn't, as far as I know, he did not see Maya. He looked at all the records, and this is going to be his response to their expert, which was Dr. Gupta. Right? No, Chopra. Sorry, I got my Indian doctors mixed up. Is that deliberate racism? I'm not sure. I didn't mean that. I apologize to the country of India. I apologize profusely for mixing up the Guptas and the Chopras. That was not intentional, and I am so sorry. Dr. Chopra was the expert on the other one. The second lady, I don't know if she saw her, Cheesy. Um, it didn't seem like it. I didn't watch like everything she said. I was just kind of, she was boring.
Was it May 1st?
May the 1st.
Okay. And tell us, if you would please, sir, where you received your background, your education and training to become a
Here we
physician.
go.
I went to medical school at the University of Arizona, Tucson, Arizona, graduating in 1977. And from there, I did a pediatric residency at Massachusetts General Hospital in Boston. Following that, an anesthesiology residency at the same hospital. And then a fellowship in pediatric anesthesia and critical care medicine at Boston Children's Hospital. And that was all finishing at the end of 1983.
Are those programs at Massachusetts General and Boston Children's affiliated with Harvard?
Yes, they are.
And did you become board certified?
Yes, I did.
And could you tell the jury what specialties you became board certified?
First in pediatrics, and then anesthesiology. Both of those were in 1985. And then in subsequent years also not long after that, in pediatric critical care medicine, intensive care medicine. And then after that, in pediatric anesthesiology, once that specialty board was established, which wasn't for a few years, and also pain medicine.
And what have you focused your practice on over the last few decades?
Initially, it was in 1984. It was a combination of pediatric anesthesiology and pediatric critical care medicine. And it wasn't long after that, about 1985, my interest began to shift to pediatric pain management, and that grew as pediatric critical care shrunk. And then it's been largely pediatric pain medicine for the last 20, 25 years.
And where have you had occasion to practice your profession?
After my fellowship training, the first place that I went to work was at the University of Washington, practicing. That was my academic appointment, practicing at the Seattle Children's Hospital. And then about 11 years later, I was recruited to go down to Stanford University, which had a new children's hospital, to be the chief of pediatric anesthesiology and to establish a pediatric anesthesiology group there.
And did you do that?
I did.
Okay. And did there come a point in which you established a
Crazy
pediatric
Warlock
pain
on
clinic?
Rumble says
Yeah,
he
we
is
set up a
not
pain
an
clinic
expert
not long
on
after I arrived at
suits.
Stanford in 1994. And it was a small clinic to begin with, and it grew rapidly over
It's a
time.
good one.
Tell us
Good one.
what the focus and scope of the pain
Oh, by the
clinic
way,
is.
if you're new here, we tell jokes. If that's upsetting to you, this is not the stream for you. You have not entered the right stream if you can't handle a couple of jokes. Chaos Coordinator, welcome to the Fox Den. Thanks for the membership. Kildada Smith, thanks for the super chat, says he talked so bad about Maya, calling her a liar and that she was faking. I know this is hard to watch. It really is, which is why we tell jokes, because this is such a serious topic and such a serious situation for Maya and her family. And it's really shitty when we have a guy on the stand who's going to look her right in the eye and tell her she's still faking. It's unbelievable.
Has been over the past 20 some odd years, 30 some odd years.
Hunter,
beginning,
why
it was
are
a
you
day a
so
week, and then it was 2 days a
low?
week, 3 days a week, and it wasn't long before it was 5 days a week. Now we're seeing maybe 11,000 appointments a year. So it's become quite busy. It's a multidisciplinary clinic. So we have on staff pediatric pain medicine specialists. Right now there's 7 of them, and pediatric psychologists, also 7. We have pediatric psychology postdoctoral students, 4 or 5 of those, physical therapists, and then we also work with occupational therapists and child psychiatry.
And as of 2016, 2017, what was your role at that point?
At that point, let's see, that was 7, 8 years ago, right? So at that point, I was just trying to. So at that point, I had pretty much stopped doing pediatric anesthesiology. It was limited to maybe 2 days a month. And not long after that, I stopped altogether. And the rest of my practice was devoted entirely to pain medicine for children.
And it did at that time, and since you've been involved in it, as the pediatric pain clinic at Stanford dealt with pediatric chronic regional pain syndrome?
Complex regional pain syndrome, yes.
I'm sorry, mispronunciated. To what extent have you been involved in the treatment, in the diagnosis, evaluation, and treatment of pediatric complex regional pain syndrome?
To what extent? Well, we see probably at the present maybe 100 new cases a year, about 2 a week, I would say, some weeks more. And we work together as a team, so it isn't as if one physician kind of owns a patient. We share the care of the patient, so I've been involved with all of those patients over the last several decades.
Okay. And what other types of pain syndromes does the pediatric pain clinic at Stanford treat?
We see a little bit of acute pain, so sometimes surgeons will send kids to us postoperatively if they're struggling.
I'm sorry. This is one of those times when the chat distracts me. Unhung Hero, thanks. The super chat says this guy probably. I can't. You broke me. We're not even 10 minutes into this. No, we're 14 minutes. I can't even read it. I try deep breaths. I try meditating for a minute. this guy probably has a lot of experience with women faking. I'm sorry. I'm sorry. I'm sorry. I must apologize for my very sense of humor and for my chat. I'm very sorry, everyone. No, I'm not. Not at all.
Dealing with their pain management, but primarily it's chronic pain. Chronic pain being defined as pain that's lasted longer than 3 months, usually past the healing of whatever initiated it. So we see a wide spectrum of pain problems. Our referrals come from orthopedic surgeons, general surgeons, urologic surgeons, pediatricians, oncologists. So we see cancer pain. We see a lot of, I'd say, complex regional pain syndrome is one of our most common, maybe the most common diagnoses. Fibromyalgia, chronic headaches, migraine headaches, chronic abdominal pain, especially functional abdominal pain, limb pain disorders. We see kids with congenital birth defects, congenital anomalies that are associated with pain. Even benign tumors such as fibromatosis can be associated with pain. So basically, like all of those patients.
Do you also have occasion to deal with patients who have psychogenic pain syndromes?
It's not exactly the term I would use. We have patients whose pain is primarily manifestation of a psychological process. We call that somatoform pain. It's not unlike patients. Well, I'll put it this way: there's a number of functional disorders. So, such as migraine headaches would be considered a functional disorder. In other words, it's functional in the sense that there's no brain tumor or brain infection or anything like that causing the headache. So the child's functional in that sense. There's also functional abdominal pain where the patient has significant abdominal pain. They go to a gastroenterologist, they get a full workup, they get endoscopy, colonoscopy, perhaps. Nothing is found. They refer the patient to us, so they have a totally functional GI tract, but they have pain. The pain is not in their head, so that's not really psychogenic pain. But we do have patients who present with pain that's not obvious from any other source, or maybe amplified pain, where we know that they have pain from some discrete source, but it's amplified to a much higher degree than one would expect it to be. And we call that somatoform pain.
During the course of your practice, have you had occasion to contribute to the medical literature regarding pediatric chronic pain?
Yes.
And to what extent have you done that?
I can't give you the number of publications. There are book chapters I've written.
Yeah, I had that question too while I was listening to this. I think he means it's functional, as in functional pain is not chronic pain, right? That's the difference. It's intermittent, maybe. Is that what he means? I don't think he means you're faking a migraine, because that would be really strange. But I have not been impressed with the pain doctors we've seen, because none of them seem to be very interested in actually getting rid of your pain, unless they're doing, like, they want you to meditate and do yoga and stuff to get rid of your pain. I mean, that might help in the long term, but in the short term, you might need an opioid or two. Yeah. Oh no, Clark. I'm not reading that. I'm not.
Edited one book and written one book on chronic pain, and many articles, but I can't tell you off the top of my head. And of course, I've lectured dozens and dozens of lectures around the world on the management of different types of chronic pain.
Have you lectured on the subject of complex regional pain syndrome?
Yes, I have. Yes, I have.
And how often have you done that? Have you estimated?
Well, there's 100 to 200 lectures that I've given over the years, some on chronic pain, including complex regional pain syndrome, some exclusively on complex regional pain syndrome. And there are a number of videos that I've made from the subject of CRPS in children.
Have you had occasion to serve as an editor or reviewer for various medical journals?
Yes, I've been an editor of a journal that's an online journal called Children, a medical journal, and I'm a reviewer for many.
All right, this is the weirdest insult, but it's going up because it's funny. Elsie Merritt says, "I'm convinced this man eats the worst selling Girl Scout cookies with an extended pinky." It's just the strangest insult. You guys are so bizarre.
Scholarly journals such as Pain, Journal of Pain and Symptom Management, Regional Anesthesia and Pain Medicine, Anesthesia and Analgesia, Anesthesiology, Pediatrics, the Journal of Pediatrics, and others.
Okay. You've been kind enough to give us a copy of your curriculum vitae or your resume. The indication is that your bibliography includes 79 peer-reviewed articles. Does that sound right?
That's about right.
Okay. And what is a peer-reviewed article?
Peer-reviewed article is an article or a manuscript that's written up to report the results of research or to summarize a subject that's then sent to a journal and peer-reviewed. Peer-reviewed means that it's sent out anonymously to 2 or 3 or 4 experts in the field internationally. They review the article, they give it a thumbs up, or they give it a thumbs down, or they give it a maybe, with that they'll accept it with alterations or modifications. Then it goes under a revision, then it's resubmitted, etc., until it's finally approved by the peers and then by the editor of the journal.
Okay. Doctor, at my request, have you reviewed probably more materials than you wanted to regarding this case of Maya Kowalski?
I have.
Okay. And I'm going to read from a list of materials that you've told me you reviewed. I just want you to let the jury know that you've done that.
I will.
Have you reviewed the records of Tampa General Hospital regarding Mr. Kowalski?
Yes.
The records of All Children's Hospital regarding Mike Kowalski?
Yes.
The records of Lurie Children's Hospital?
Yes.
Dr. John Wasenauer's records?
There's another oddly specific insult from Rumble. You guys are so weird. Who said it? Wait. Where did it go? Oh no, I lost it. Oh, Jared of the Dead. He probably eats corn the long way. What even does that mean? You mean like a typewriter? Like, is the right way around? I mean, I eat it around, but like this way? You guys are a mess.
Records?
Correct.
Dr. Kirkpatrick's records?
Yes.
Dr. Hanna's records?
Yes.
The records of agility, PT, and sports performance?
Yes.
The Eagles wing rehabilitation records? Or records of?
I believe so. Yes.
The records of the Sarasota County School Board?
Don't remember if I've reviewed those actually.
Okay. Have you reviewed Dr. James Lewis's report?
Yes.
And the report of Dr. Chopra?
Yes.
Dr. Sally Smith's evaluation?
Yes.
The evaluations of both Maya and Beata Kowalski by Tashana Duncan?
Correct.
And then the depositions of Mr. Kowalski?
Yes.
Dr. Elliott?
Dr. Elliott, yes.
Dr. Wasenauer?
Yes.
Dr. Hanna?
Yes.
And I think I asked you if you reviewed his records. Have you reviewed Dr. Hinchke's records?
I don't remember. Who's he again?
Hinchke,
Hinchke?
psychiatrist.
Yes.
Have you reviewed the depositions of Drs. Hanna, Revivo, and Santana Rojas?
Yes.
And the depositions of Dr. Cantu, as well as that of, Dr. Cantu.
Yes.
Okay. Are there other records that you've reviewed regarding the case?
Yes, there are some blog entries by Maya's mother and some emails from Maya's mother to herself. And let's see what else. Some photographs of Maya at different times of her life.
Okay. All right. Let me backtrack a bit if I can and just ask you some general questions regarding complex regional pain syndrome and some of the other syndromes that bring us together today.
Yeah.
Tell the jury, if you would, what chronic regional pain syndrome is from the standpoint of someone who treats that condition in your specialty.
Complex regional pain syndrome.
I'm sorry, what did I say? I'm sorry, complex regional pain syndrome.
A lot of people do that because it is a chronic regional pain syndrome. So complex regional pain syndrome means what the words say. It's complex, it's complicated.
Kildada Smith, thank you for the super chat. $19 super chat, $20 super chat says Sally the witch is flying in on a broom in 2 days. Oh, really? What am I doing in 2 days? I hope I'm going to be here. I have a appointment tomorrow. I don't know. I'll have to look at my schedule.
The cause of it is not known. There's several hypotheses, but over the last decades, we still haven't nailed down exactly what the primary cause is. There's probably a genetic vulnerability that leads to it. It's regional in that it affects a region of the body. Typically, in children, a leg. Typically, in adults, it's an arm, which is mainly a factor of what kids are doing versus what adults are doing. Kids are running around soccer fields and football fields and baseball fields and have leg injuries, very common, twisted ankles, for example. Whereas adults don't do that, but they'll oftentimes trip and fall and break their fall with an outstretched arm, and that will start it off. It usually follows a rather trivial injury, like a sprain. It can obviously follow a more significant injury, like a broken bone. Sometimes it follows surgery. It affects initially one limb of the body that has had the sprain or the operation or the fall or what have you. And it begins at some point after that injury occurs. I have a colleague who's an orthopedic surgeon who gets CRPS repetitively. He's an outdoor runner. He's a trail runner. So he's frequently stepping in gopher holes or snake holes and twisting his ankle. And what he tells me is that
yeah, it doesn't matter what your friend with CRPS goes
at some point in time.
You know, one thing about this trial and all these testimonies that really bothers me, and this is the truth for everybody with a medical condition, there isn't one person on earth who experiences the same thing the same way, because everybody's different. And so she is experiencing her condition the way that she is experiencing it. And it might be, it is probably different than every other person on earth who has it. Not to mention, according to her doctors, she has one of the more severe forms. I don't know why these people are insistent on telling her and her family that she does not experience her symptoms the way she experiences it. The hell is this anyway? I'm so tired of it. I'm tired of this. I'm tired of this these excuses about, well, it's not like my friend Bob who runs on trails and steps in snake holes. Why does that sound ridiculous? Why am I laughing? This guy's trying to compare her to some dude named Bob who runs through dangerous trails and steps in snake holes. You know what my advice to Bob is? Quit running on those trails, okay? But just because Bob has a problem with the snake holes and his CRPS flare-ups does not mean that Maya is going to have the same thing. And I'm tired of them all saying she doesn't fit into this box. And because she doesn't fit into this box, she can't possibly have this syndrome. These people just need to off you fuck.
Week or two after the injury occurs, the pain shifts from the pain of the injury, a twisted ankle or what have you, to what we call neuropathic pain, which is pain that has its origins in the nervous system. Oftentimes by that point in time, the original injury is healing. And the pain is very different than the kind of throbbing deep pain of a broken bone or a twisted ankle. The pain moves to the surface of the limb, the skin, which has a burning quality. It becomes exquisitely sensitive to touch. Even the lightest touch, such as pulling a garment of clothes over that skin, is so excruciating the child can't do it. They can't sleep with bed sheets over their affected leg. They sleep with their leg either dangling off the bed or on top of the bed sheets. And then there's physical findings associated with it as well as the symptoms the child's reporting. Very specific physical findings. This goes on for a length of time until treatment begins.
And what, in your experience, is well, first of all, you describe for us how many cases, or an estimate of how many cases the pain clinic at Stanford has seen.
And why do we have to hear about that?
How frequently does this disease occur in pediatrics?
Unhung Hero sends a super chat. Why is he so obsessed with Bob's holes? Now I'd like to know, and why do we need to hear about them? I don't know. I don't know what Bob has to do with this trial. I really don't. But Bob should be more careful out there on those hiking trails with snake holes. Busy B72, thanks for the super chat, says they do that to almost everyone. I spent 30 years being told I was mentally crazy. Well, let me tell you something, Busy B. I am so sorry. That happened to my mom too. She really had an autoimmune disorder, but for years she was told that she needed psychotherapy. No, that's not what she needed. She had an autoimmune disorder that kept her in bed for 6 years. 6 years I watched my mom. I thought she was going to die. When I was 10 years old, she came down with this Epstein-Barr that is now chronic fatigue, and I thought she was going to die, and all these doctors were telling her that she was sick in the head. But that wasn't true. You only know what you know when you know it, and not before. And I think that this is one of those things. It's like whatever Maya has, it certainly is CRPS-like. Perhaps it's a different kind. Perhaps it's something nobody's seen before. But what the hell? Can we try to have some compassion and empathy for a sick kid who's in serious pain? None of these people are claiming she wasn't in pain. Do you notice they're trying to have it both ways? They're like, well, she was in pain. She was writhing in pain. But then the next day we saw her, she wasn't writhing in pain. So, good Lord. Regardless of what her diagnosis is, the way the medical community has treated her is absolutely horrific. And I hope it never happens to them or their kids. McCrae, thanks for the super chat, says, just wait till he gets to the pictures, and concludes that because she's smiling, she's happy and pain-free. Oh my God, stop it. I can't even.
And most pediatricians will never see a case in their entire career. So it's that infrequent. Consequently, most pediatricians aren't even aware of it or don't know what to do with it. Typically, somebody comes in with this exquisite limb pain and they'll send the child to an orthopedic surgeon. And most orthopedic surgeons are aware of this problem because it occurs in their practice. And then they'll send the patient on to a pain clinic. Sometimes it's seen by a physical medicine and rehabilitation specialist, sometimes a neurologist. So the frequency is not really known. It's probably on the order of 1 in 100,000 children that get this. But as
1 in 100,000 children who get it. And I'm supposed to believe that even all the doctors they brought up on the stand, all of them, the whole train of them, I'm supposed to believe that you know what you're talking about when it's a 1 in 100,000 child scenario. Rafe says they would be more compassionate if she said she were really born a boy. This is not a joke. This is actually true. If she lied to them and fabricated some kind of gender dysphoria in her head, they would have been more compassionate to her. Yep. There's only certain lies you can tell in the medical community, though. Only some lies. Other lies, not so much. The lying, exaggerating your pain is not allowed. but telling a medical professional that you with the ovaries and the uterus are actually a male, that lie is acceptable.
As I said, it's so infrequent that most pediatricians aren't aware of it and will never see it in their lifetime.
How is it that your clinic sees that many patients if it occurs that infrequently?
Well, there's something like 50 million people or 45 million people in the state of California. We're the only multidisciplinary pain clinic in the state of California, the fullest service pain clinic. So we get referrals from all over the state, as well as from neighboring states, Washington, Oregon, Arizona, Utah, Nevada, and as far away as the East Coast. We've had patients come to us from Virginia, Boston, Pennsylvania, and we've had patients come to us internationally from various countries in South America, Australia, New Zealand, England, for example. We get patients from all over because of the reputation that we have.
And to what extent, well, within the universe of pediatric complex regional pain patients, how many
I know, I'm worried about Bob
so-called
now.
whole body CRPS?
How are those ankles
Nobody
doing?
knows.
And why is that?
Because, as I said, it starts in a limb. It's a regional pain syndrome. It can, in some cases, spread, and it does spread, but not right away, not early in the disease. Usually it's after months or actually more like years. It can affect the opposite limb. It can spread proximally. It can affect the arm. So it can spread, but it typically spreads to other limbs. It doesn't spread to other parts of the body. I can't say why that is, but that's certainly the case.
What is the recognized treatment in your experience for pediatric complex regional pain syndrome?
The most important, the foundation of treatment, the kind of treatment without which it will not get better, is physical therapy and occupational therapy. Occupational therapy is a little bit different than physical therapy, even though the child doesn't have an occupation, it's still what it's called. But a combination of physical therapy, occupational therapy, and psychotherapy by a qualified psychologist. Those are the fundamental things that will make it better. Everything else, we do other things, of course. Everything else that we do for CRPS, complex regional pain syndrome, is only useful in as much as it supports physical therapy and occupational therapy. So, for example, if the child cannot tolerate physical therapy because their limb is so painful, we might add medications to reduce the pain. We can't eliminate the pain, but we can reduce the pain. You might do a nerve block to put that limb to sleep, which is effective for a limited
wait a
period of time.
minute. Hold on. Wait a minute. You use anesthetics to help the pain? What kind? Do you use opioids, doctor? I like the part where he gets to where he uses ketamine, too. Ginger with the Soul says, I'm 10 minutes behind catching up on 1.5 speed. We're a bunch of weirdos, Megan, but we're your weirdos. This is true. I am happy to be stuck with you. Yes, I am.
Block the nerve for weeks or months, but we can for days to get started in physical therapy. So the other things that we might do are only useful in as much as they facilitate the practice of physical therapy, without which we can't make patients better.
Is there a role for ketamine in the treatment of pediatric chronic complex regional pain syndrome?
We do use ketamine at Stanford. There's a number of places around the country, a small number of places around the country, that use low-dose ketamine in children. There are still many, if not most, children's hospitals, if they have a pain service, restrict the use of ketamine to the intensive care unit environment in any dose. We have a more liberal hospital, and we were able to convince them that using low-dose ketamine outside the intensive care unit is safe. And it's something that we reserve for refractory cases that we cannot make better after a full court press. It could be intensive physical therapy every day for weeks, typically 10 or 12 weeks, psychotherapy every day for the same period of time, and using all the drugs that we have on the shelf that are to some degree effective in CRPS. If those things don't work, we will then put the child in the hospital for a 5 to 7 day ketamine infusion. But as I said, it's a low-dose ketamine infusion in contrast to what was used in Maya.
While we're on that subject, can you define for the jury a low dose as opposed to a higher dose?
Our ceiling maximum dose is 1 milligram per kilogram per hour, which we've only used in one patient over the last decades. Typically, we start at about 0.1 milligram per kilogram per hour, and we increase the dose every 6 or 8 hours by 0.1 milligram per kilogram per hour until we reach a dose which is effective in reducing pain, or a dose at which unacceptable side effects occur, or a dose at which sedation occurs. And then that becomes our ceiling. So typically, our dose is going to be in the range of 0.3 to 0.6 milligrams per kilogram per hour, except for that one patient in whom we had to go to 1.
The jury, I think, has heard the term anesthetic dose of ketamine. What is that?
And ketamine, you have to realize, is a drug that has conventionally been used as a general anesthetic. You can put somebody to sleep and operate on them with ketamine. The dose that is necessary is a starting dose of about 1 to 2 milligrams per kilogram given intravenously. So that would be about 27 milligrams to 50 milligrams in somebody the size that Maya was back then. In an adult, it would be 70, 100, 150 maybe milligrams. And then about 3 milligrams per kilo per hour will keep them asleep in order to do an operation. So you can take somebody's appendix out at 3 milligrams per kilogram per hour.
Okay. Now, how does that compare with the dosages?
All right, so he's going to get into now why it's such a terrible thing that she got high dosages of ketamine. And I just have to say, this entire case, this entire situation should never have happened, even if her parents made the wrong decision and the doctors they went to did a too high of a dosage on ketamine, and they were sending her down the wrong road. Even if Is the medical community pretending to me that they don't kill 400,000 people a year through hospital negligence? Because they do. It's the number one, I think it's the highest rate of death in the nation. Maybe it's right underneath car accidents, but look it up. Medical negligence, hospital negligence kills more people every year than almost everything else. And these are the people who are going to judge a family for seeking out answers to this super rare thing. When their kid is screaming in pain all the time, you're gonna blame them, and for that they deserve to be harassed, tortured by the state, separated from their kid, driven to suicide. Yeah, I don't think so. Doctors make mistakes all the time. They make mistakes all the time. Suddenly, if these doctors, Kirkpatrick and Hannah, if they made mistakes, suddenly it's the parents' fault, and it's the end of the world, and everybody we need to have a the state needs to come down with a jackboot on top of it. But what happens when doctors kill your grandma because they didn't read the chart right and they gave her a medicine that she wasn't supposed to have on top of the other medicine that they had already given her, and now she's dead? What happens there? Good luck suing. You won't be able to. Suing for medical negligence is damn near impossible. Nick Campbell says every doctor should wear the period pain device and the patient gets the remote so they can explain it hurts this much times 10. Miranda Lee says it's upsetting, but he totally redeems himself. He calls Maya by the name Hannah. Oh, facepalm. Does he really? Oh, Unhung Hero. So it's crafting a pseudo penis from a chunk of arm skin. Sorry, I read that wrong. Is crafting a pseudo penis from a chunk of arm skin compassion? Well, according to these doctors at Johns Hopkins, yes, because they have one of the oldest gender clinics for kids there, and they're cutting off healthy body parts. I don't know what to tell you, but apparently that's okay.
Used in this case by Doctors Kirkpatrick and Hannah. Objection.
Sidebar. Thanks for the super chats, you guys. You guys are really on top of it today. Appreciate that. I forgot to scroll my Venmo across the bottom of the screen. I guess I should do that. Hold on. I will as soon as we get past this sidebar. If you prefer Venmo or Cash App, you can always use those instead of Google. Also, don't forget to hit that like. There's 352 of you here on YouTube. Make sure you hit that thumbs up button. I know your thumbs aren't broken. I know you can do it. I believe in you. I'm proud of you. Your internet mom says she believes you can hit that like button. I believe you can do it. You can do it right now. And Rumble, you too.
How does it compare to the doses that Kirkpatrick and Hannah used?
Yes, sir.
Kirkpatrick started around, I think, a milligram per kilogram per hour, and over 4 days ramped it up to 2.5 milligrams per kilogram per hour. I don't remember what Hannah's starting dose was, but it was substantially higher, and went up even higher and higher still, so that by October of 2016, he was using doses in the range of 25 to 30 milligrams per kilogram per hour, 10 times the typical anesthetic dose for a patient.
Okay. Going back, well, let me ask you to focus on the period of time between September 23rd, 2015, when the patient first saw Dr. Patrick, and the time she came to All Children's Hospital. Can you describe the course of her therapy and disease during that year?
Yeah, the course that she demonstrated was one of perpetual reports of severe intolerable pain, weakness, inability to use her limbs, inability to bring her ankle back to a neutral, normal position where the foot is about 90 degrees to the foreleg, and behavior that was often described as a screaming type of behavior, which was attributed by her mother, and her doctors to severe pain, and that there was an undulating course, and that there were episodes in which, or time periods in which her pain seemed to be less, and then severe pain again, and then less, and then severe pain. But overall, if you look at the entire landscape from September of 2015 or summer of 2015 until the fall of 2016, you have to say that she was no better, in fact, getting a lot worse.
Was there any difference in function as far as the patient was concerned during those 2 dates, as far as you could determine?
When her function was much worse by the time October 2016 came around and she was admitted to All Children's Hospital, she said that she could not move her limbs. She could not lift them against gravity off a bed. She had significant pain, so that she would be screaming in pain, would not tolerate anybody touching her. Her mother would not allow anybody to touch her because of the pain that would occur.
Going back, if we could, to the point of Dr. Kirkpatrick's initial involvement in September of 2015 in the therapy that he offered. Do you have an opinion that you can state within a reasonable degree of medical probability whether the treatment he offered was within the standard of care for the treatment of pediatric complex regional pain syndrome in this country?
It was not within the standard of care.
And why is that?
As I said earlier, ketamine is reserved in our institution nationwide for patients whose pain is refractory and unresponsive to the fundamental treatment, which is, as I said and will repeat, intensive physical therapy, advancing to intensive physical therapy if necessary, occupational therapy, psychotherapy, drug management as an outpatient, oral drug management. His first treatment was ketamine. So it was, at the very least, it was very premature.
Whoa. That's false. His first treatment for her was ketamine, but she had already been in an inpatient at Tampa General. She had been in a inpatient thing with Bonnie. You remember Bonnie Rice. She had been there for like a month or two. Remember Bonnie Rice? Tough diagnosis, mind read your way to an answer. And she didn't get better. She did the intensive inpatient therapy with Bonnie Rice. She did all of those things that he just said. She already did that. She tried that. Why on earth, if you go to a real doctor and you've already done these things and you've shown them that, like, look, I already tried this intensive therapy and it didn't work, and it's not making her stronger and it's not making her pain. So of course he's going to go to something else if he's a good doctor. What kind of doctor then goes, okay, well, let's try the same thing that failed first before I give you an alternative? How does that make any sense? Sorry, no.
In addition, the way that he administered ketamine, which was in significant doses, was a violation of the standard of care in terms of his record keeping. There are specific not recommendations or guidelines, there are specific ways that records need to be kept during anesthetic type infusion as he administered to Maya. And remember that going up to 2.5 milligrams per kilogram is virtually a gentle anesthetic. His record keeping was just terrible. It was skeletal, minimal at best in terms of measuring vital signs and recording level of consciousness. That is to say, it violated the standard of care for an anesthesiologist.
Well, if that's the case, then why didn't the state go after him? He's a Florida doctor. Kirkpatrick, remember, he's got his office next to Busch Gardens. Remember? He's an amusement park doctor, according to the defense. I mean, he's under the jurisdiction of Florida law. So if his records were so bad and what he did was so awful, where the hell is law enforcement then to come haul him out in handcuffs and hold him accountable? Why are we holding Maya's mom accountable for something that a doctor did? This is my whole problem with Munchausen syndrome by proxy allegations, because more often than not, it is the medical community not knowing what the hell to do or making mistakes, and then mom gets held accountable for their mistakes. It's not okay. If medical doctors that I trust are telling me to do stuff, I'm like, yeah, okay. If this is what we have to do and we've tried everything else, then yeah, I'll do it. How am I supposed to know? How is she supposed to know?
Harm to Maya Kowalski as a result of this?
There was no harm to Maya.
Oh, all right. Case closed. There was no harm. Wait a minute. There was no harm. She didn't have any harm. Case closed. Get off the stand. It's over.
In terms of specifically receiving the ketamine, fortunately, she didn't have any complications from it. And not surprisingly, her pain reports were diminished after ketamine, because ketamine is not only just a great analgesic, it also has psychiatric effects, which you may be aware of. You may know that ketamine is being used more and more frequently by psychiatrists to treat depression and anxiety, which isn't to say that that's what she had, but only to say that there are emotional/psychiatric effects of ketamine. So in that sense, she was no.
Okay, so the ketamine made her feel better because it has really good results on helping people with anxiety. So it didn't hurt her. It actually helped her. On Rumble, Jill Bell 70 just brought up something that I need to point out. She said, but isn't that what one nurse said? That they don't have time to chart everything. Yeah, how dare he go after Kirkpatrick for his incomplete charts? There's no time. There's just no time to chart everything. That's a very good point. Yeah, Crazy Warlock goes, wait, what? So what's the fucking problem then? She went, no harm. What harm was done to her with the ketamine? None. Zero. Ah, okay. But we banned her from having any more, though, in the future, because, the court did that. The dependency court ruled that she's not allowed to have ketamine therapy anymore. Because, it's the government's business what kind of pain medication you can have.
Worse. But I would say the harm that was done was that instead of being referred to a center that knows how to take care of pediatric CRPS, he went ahead and administered ketamine. And then when that really didn't work, it didn't provide sustained benefit, he referred her to Mexico. And that's another story that you'll probably get into, I suppose, with your questioning. But I think the important damage that was done was in denying Maya effective therapy for CRPS, and we're assuming this is what she had at that time, because if she had CRPS and if she had effective therapy for it at her age, I would have expected her to improve and recover in a matter of weeks, and that wasn't done.
Okay. And that's something I hadn't asked you before I go to Dr. Cantu. Was there an adequate trial of alternative therapy before the ketamine was given?
There was not.
And if there had been, if you compare what might have been, so to speak, if the program pursued was similar to your clinic, what is the outcome that is expected or anticipated for a child such as this receiving standard of care therapy?
Maya, I think, was about 10 years old at the time. And I would say that 10-year-old girls, and I say girls because it's about 7 or 8 times more common in females than in males. So almost all of our patients are females who have CRPS. And we don't know why that is. But 10-year-old girls with CRPS.
We don't know why that is because we don't know anything about any of this. Nothing.
Are our favorite population to take care of with CRPS. Why? Because they're the easiest to take care of. They recover the fastest and they don't recur. Of all the kids we've taken care of, we've never had a recurrence of CRPS in a child.
So he's a miracle worker, guys. Jesus is on the stand. He's healed. Did you hear that? He's healed every 10-year-old girl with CRPS who has been through his therapy. I'd like to talk to his patients because that seems impossible. What we've heard about CRPS is that it is not curable and that it has flares and comes back. And he's going to try and tell us that he healed them all. He's healed every 10-year-old girl with CRPS. And if only they had brought, Maya to him, she would be healed. That's not Jesus. Jesus is in the trash can. This is K-Grip. And I have proof. I have photographic evidence that Jesus is in the dumpster. So you're right. This can't be Jesus. But I don't know. Maybe the Apostle John? I mean, what is he trying to sell us here? He is trying to sell us that he is a miracle worker and that what he does, he's just healing all these 10-year-old girls with CRPS like crazy.
Whom we've treated at the age of 10 or 11 or 12. As kids get older, it becomes more difficult to treat, more challenging. And as children advance through adolescence, their teen years into their young adult years, it begins more and more to take on the pattern of adult CRPS, which is a much more difficult condition to treat.
Let's talk about Dr. Cantu's treatment. Can you describe for the jury your perception of what it consisted of?
His was called ketamine coma. It was coma in the sense that a patient on the kind of doses that Cantu uses is going to be unresponsive, unconscious. In other words, under general anesthesia. So it's not really coma, but he's giving general anesthetic doses. So the patient is under general anesthesia for the...
Nick, this is a great point. Doctor, just because they don't come back because they find a second doctor who actually addresses the problem doesn't mean they're cured. Yeah. Right. And if he didn't heal them, he can just say they were faking. That's right, Mama Ames. Exactly.
5 days of this infusion, which starts at 3 milligrams per kilogram per hour and advances day by day to a higher dose. I think the highest dose that Maya received was 5 milligrams per kilogram per hour, maybe 6. Those doses result in complete general anesthesia or coma, which I don't think is a correct term to use in that instance. For that reason, Dr. Cantu has to treat the patient as if they're under a general anesthetic, which is what we do in the operating room, except that he's doing it in an intensive care unit, which is a good environment for that. Patient is intubated, that is, they have a breathing tube placed into their mouth, down their windpipe. It's attached to a mechanical ventilator to breathe for the patient because they won't breathe adequately on their own. They have to place a tube in the stomach, either to decompress it or to provide nutrition, which was done in Maya's case. So they are basically under a prolonged general anesthetic for 5 days.
Is there, is that treatment, in your experience and based on your background and training, within the standard of care for an anesthesiologist providing care for pediatric complex regional pain syndrome in the United States?
It is not. It is not within the standard of care, and that's why it's not done anywhere in the United States.
Let's move on.
Medium smart.
It appeared to you, but
Who did that? Someone has come over. Their YouTube name is Medium Smart. Medium Smart says, well, it could be Jesus. It has been more than 3 days. I have it on good authority. He didn't stay in the dumpster long.
based on the review of the records that you saw and the depositions you reviewed, did it appear that the treatment rendered by Dr. Cantu in Mexico was successful in any sense of the word?
It wasn't successful in the sense that any benefit that she realized was not sustained over a significant period of time. So within 4 or 5 or 6 weeks, she was reporting an increase in pain. And that's in contrast to the patients that we have experience with and other places have experience with in the United States with low dose ketamine, low dose being 1/10 the amount that Dr. Cantu used, in which the benefit in CRPS is sustained over several months.
Now let's talk about the care that, well, let me back up. After seeing Dr. Cantu, this patient was seen by Dr. Hanna, correct?
Correct.
And describe for the jury what Dr. Hanna's course of treatment consisted of.
Dr. Hanna saw Maya from December of 2015, about a month and a half after she returned from Mexico, until he sent her to All Children's Hospital October the 7th of 2016, so over a period of nearly a year. His treatment involved giving Hannah infusions of ketamine over several days each time, over 4 days each time, in ever increasing doses. So he started off using doses similar to what Dr. Cantu finished with. And because she kept coming back over and over and over again with increasing complaints of pain and no improvement, according to his notes, she continued to have dystonia of her feet, allodynia, which is this exquisite pain with light touch of the skin, etc. He kept giving her higher and higher and higher doses.
How did that finish? How did Dr. Hanna's treatment finish in October of 2016?
Because of the excessive doses of ketamine, she was losing weight. She had lost appetite. Her weight had fallen. She was not on her growth curve. Not only had she stopped gaining weight as children do as they grow, she started losing weight. She was at the first percentile, which means that 99% of children of her age weighed more than she did. And she had terrible abdominal pain. And that was one reason that he sent her to the emergency room at All Children's, was because of the abdominal pain. And she had had some episodes of abdominal pain associated with these high doses of ketamine prior to that time. So it was something that had been getting worse and worse.
Was Dr. Hanna's therapy of Maya Kowalski successful?
It was not, in the sense that it was necessary to send her to All Children's Hospital. I think at that point in October, he could not bring himself to give her more ketamine. He knew that the ketamine dose that he was giving was so high, he just couldn't imagine.
Can we hear from Dr. Hanna, please? How come we haven't heard from Dr. Hanna? Dr. Hanna never testified, I don't think. Did we hear from Dr. Hanna yet? I feel like I didn't. Did I miss it?
Giving more. And at that point, he bailed out and sent her to All Children's Hospital.
Did Dr. Hanna's care and treatment of Maya Kowalski comply with the standard of care for an anesthesiologist treating complex regional pain syndrome in the pediatric setting in this country?
Objection. Foundation predicate beyond scope. All scope.
Again, it did not. And it did not because of several factors. The one most glaring factor is the dose of ketamine that he was using and the way he was using it. And during the infusions, as was the case with Dr. Kirkpatrick, she was inadequately monitored and there was inadequate recording of the safety of this, vital signs, etc. He was giving anesthetic doses, and yet was not recording things as an anesthesiologist should, documenting safety.
Was there injury or harm to Maya Kowalski as a result of the course of therapy that Dr. Hanna pursued?
No objection. Overruled.
And I would add that
Foundation predicate.
I would ask that within a reasonable degree of medical probability.
There was harm. The harm was, as I said, that she was developing complications, weight loss, loss of appetite, etc., from the ketamine therapy. At least I think it was from the ketamine therapy. There was no other obvious or possible cause.
Oh, so you don't know? Oh, I think at least I think it was. I think it was from the. You know, if you've seen pictures, photos of Maya from the time she was little until now, she's a very small, slight thing. All this stuff about the chart, the growth chart, the chart is a guide. If you're under it or over it, you know, that's going to happen. No, he's not calling her Hannah, I don't think. I think he's talking about Dr. Hannah, but I think he did call her Hannah one time.
Cause for that, except the high dose ketamine. She had no other reason to be losing weight. And also because, as was the case with Dr. Kirkpatrick, he denied her the opportunity for effective therapy for CRPS, if that's indeed what she had.
She had that therapy with Bonnie Rice. She did. She had that therapy with Bonnie Rice and it didn't work.
Now, let's shift gears, if we can, to the patient's admission to Johns Hopkins All Children's Hospital on or about October 7th of 2016. Have you reviewed the entire record of that hospital visit?
Yes, I have.
Do you have an opinion that you can express to us within a reasonable degree of medical probability with respect to whether the care that was rendered to Maya Kowalski during that admission complied with the standard of care for hospitals and physicians taking care of pediatric complex regional pain syndrome in the United States?
Overbroad, beyond scope, foundation predicate. Overruled.
Yes, I do have an opinion, and my opinion is that they did comply with the standard of care.
Would you explain the basis for your opinion, if you would, please?
Well, there was so much done. There were so many things that were done for Maya in the hospital that I have to address some of them individually. First of all, she came to the emergency room with a complaint of abdominal pain. The emergency room physician noticed immediately that her symptoms did not correspond to her physical examination, so there was a big discrepancy there. And of course, she came with a history of getting these huge infusions of ketamine, with which they had no experience. I've never heard of infusions of ketamine that high. And they realized that some of the symptoms that she may be manifesting were a complication of that ketamine therapy in some way or another, and it was necessary to hospitalize her. If for no other reason, to effectively treat the pain that she was reporting, but also to deal with this enormous dose of ketamine, what they were going to do with it, and to treat the pain and disability that she was manifesting. In the intensive care unit, they needed to put her back on a ketamine infusion. You might wonder why they were doing that when I said it wasn't an effective therapy for her, and that's because she had become physically dependent and tolerant of ketamine.
That's not what they testified to. Nobody at that ICU at Johns Hopkins testified to giving her ketamine because she was dependent on it. If that's what they were going to go with, don't you think they should have testified to that? Not one of them said that. They were weaning her off because she was addicted. They know they can't make that argument because ketamine's not addicting.
The fact that she could still be awake on 13 milligrams per kilogram per hour of ketamine tells you that she had become incredibly tolerant. She had become unresponsive to the ketamine.
Or her body chemistry is just different than most.
Which was, I suppose, the basis for Dr. Hanna to keep ramping up the dose, which is a violation of the rule of what I call the rule of holes, which is when you're in a hole, stop digging. He kept digging deeper and deeper and deeper and making her more and more and more and more dependent, physically dependent on ketamine.
The rule of holes? Does that include snake holes? You better talk to Bob about that.
Common term for that would be addiction, but it's not really quite what I would call an addiction, but certainly major physical dependency and tolerance.
So it's not an addiction. What? Just said that she was addicted to it. Now it's, well, not an addiction, but dependency, because yeah, that's different.
So they needed to put her in an intensive care unit to take her down from ketamine in a controlled fashion, to wean her from ketamine to prevent overt ketamine withdrawal, which would have been a very unpleasant thing for her. At that point, they still needed to keep her in the hospital. Her evaluation wasn't complete. And that also, while she was in the intensive care unit, they began to develop concern for the fact that Beata, her mother, was saying that she was going to take her out of the hospital and take her back to Dr.
Objection,
Hancock.
check 39 would strike.
On this one.
Mama Ames says, Bob objects. He's the expert on holes, sir. It's funny. All right. I think I missed something. Oh yeah, this one. Jessica Therian, thank you for this. He says, see, she's still complaining about allodynia, so the treatment isn't working. Later, he will say that she never had CRPS or allodynia because she's wearing socks. Can't have it both ways. You know what? Somebody else testified that she was wearing skinny jeans at times, and that goes against the allodynia. And yet the defense has not shown us one picture of her.
The last comment that the witness made.
They're not going to show us one picture of her wearing those skinny jeans. The only pictures we've seen of her, she's been in shorts. What was the last comment that's being thrown out? I can't remember what it was he said.
Mr.
Anybody
Hunter, you may
remember?
continue.
Yes, Your Honor. Thank you. Let me ask you some specific questions about this, if I could, Doctor. First of all, was it reasonable for the physicians and staff at Johns Hopkins All Children's to attempt to wean Maya off of the medications that she had been getting?
Yes, it was.
And tell us why that would be.
As I said, she had come from Dr. Hanna's office after an infusion of a very high dose of ketamine. She was physically dependent on it by history, and it was necessary to wean her from ketamine in a controlled fashion over days to prevent her from having withdrawal symptoms.
Was it reasonable? Well, let me ask you this. Was it reasonable for them to attempt to transfer this patient to a facility more able to deal with her complex regional pain syndrome?
That wouldn't have been the priority at that point in time, but ultimately it would have been appropriate to transfer her to a center that knew how to take care of complex regional pain syndrome in children.
Okay. And the priority at that point in time would have been to do the weaning and
Correct.
take care of the acute problem.
Yes.
As the treatment at Johns Hopkins All Children's proceeded, was it reasonable for them to attempt to treat? Well, strike that. Let me back up. What would have been the appropriate treatment of this child at that time at Johns Hopkins All Children's or at any other institution that was similarly situated?
You can't treat without a diagnosis. It was, I think, clear to them after the pain management consultation that she didn't have complex regional pain syndrome. They needed to determine exactly.
No. They said they couldn't rule it out. This guy is testifying in contradiction to what Johns Hopkins has already testified. They said they couldn't rule it out. Oh, that's a face. I'm going to get that on the get a screenshot of that. No.
What was causing the problems that were causing her symptoms?
What were the other possibilities that might be considered in the diagnosis on this patient at that time?
The important thing to realize is that the symptoms that Maya and her mother.
Ground scope palpitations in psychological.
Approach.
And we're approaching again. Poor Maya has to sit here and listen to these people deny her pain again. It's awful.
The initial diagnosis upon admission was complex regional.
Wait, what did the judge rule?
You saw, well, did you see in the record this way, Doctor? Let me just ask a question this way, Doctor.
He has to rephrase it.
Did you see in the records that there had been that the initial diagnosis upon admission was complex regional pain syndrome?
I don't know if you're referring to the note from the pediatric intensive care unit resident, which it didn't exactly say that. It was number one. I think it said something like CRPS diagnosed by outside person.
No, it didn't. No, it didn't. It said CRPS. We saw it yesterday.
Right. That's not the same as saying she has CRPS.
Okay. Do you have it? And as time went on, that diagnosis by history remained in the chart, correct?
Yes, it did.
Okay. Do you have an opinion with respect to whether this child had, at that time or even today, complex regional pain syndrome?
Today, I can't answer, of course, because haven't seen mine. I haven't read any very recent reports of how she's doing, but I didn't see.
Can you get a little bit closer to the
Yes,
microphone?
I'm sorry. I said I can't comment on today, but I didn't see anything consistent with the diagnosis of CRPS, except the report of pain as just pain, but because there's a lot of things that cause pain, of course, but including CRPS. But I didn't see anything to suggest to me that she had CRPS at any point in her history.
Do you have any opinion regarding what her diagnosis was during the time she was at Johns Hopkins All Children's Hospital?
Sustained as phrase.
How can he have an opinion on a diagnosis?
What were the alternative diagnoses
A kid
that a
he's never
physician
seen.
such as yourself?
Hold on a second.
How does he diagnose somebody he's never looked at? That doesn't make any sense. Don't allow it.
Doctor, let's talk about the chronic regional pain opinion you just expressed. Why do you say that there was not a diagnosis? Why do you say that CRPS was not the diagnosis this time?
Number of
By this
reasons.
time, I mean at the time of admission and during admission.
Well, looking at her history, she.
That one's allowed.
Should I continue?
Yes, go ahead.
Well, looking at her history, she didn't present as a patient with CRPS, and she didn't meet the usual criteria that we use for diagnosing CRPS.
Would you explain that, please?
There was a meeting that was held in Budapest in the late 1990s, I think. It was a meeting of the neuropathic pain interest group of the International Association for the Study of Pain, and they established specific criteria for the diagnosis to make the diagnosis of CRPS. And she did not meet those criteria.
In what respect?
The criteria include features on a physical examination, which are differences in the temperature of the affected limb to other limbs. It's cold. It's generally colder. Color changes, generally speaking, blue, purple color. In the very earliest phases of CRPS, it can be red, overperfused, but generally speaking, the limb is cold and blue or purple. There are secondary changes to the skin and hair growth, and there are motor abnormalities, such as tremors or dystonia. And the most important,
She had all of those things.
Diagnostic criteria.
We
and
saw the
final one-
pictures of her discolored leg that was kind of a reddish purple, and we saw the dystonia. So far, we're 1 for 1 here, sir.
is they list criteria for symptoms reported by the patient, A, B, C, and D, and then physical examination features that are seen by a physician, A, B, C, and D. And the final diagnostic criteria is these things cannot be explained by another diagnosis. And that's important. So if there's another diagnosis that can explain the cluster of symptoms and signs, then it's not CRPS.
During the period of time between September of 2015 and the patient's admission to All Children's in October of 2016, was there ever any definitive effort to rule out, you could tell from the records, to rule out other diagnoses as a cause for her symptoms and her presentation?
Objection to extended straight into the area.
You can answer that right now.
She had been seen with this cluster of symptoms at Tampa General Hospital, at Lurie Children's Hospital in Chicago, and Johns Hopkins All Children's Hospital in Tampa.
You're referring to 2015.
Yeah, in 2015. Each of those institutions, independently of each other, said that it was not.
I object. Independently of one another? No. They saw the files. They were not independent. So they saw the indication on one doctor's file that it was conversion disorder, and that colored their opinion of the entire case. Each one. They were not independent.
Not CRPS, and noted that there were very significant discrepancies between the symptoms that she was reporting and their physical examination findings. So coming to a diagnosis when faced with that is a slow process that requires a long period of observation in order to decide exactly what's going on. But we know that there was no organic reason for what was happening at any of those points.
There has to be an organic reason. This is God. I would not want a doctor like this. There has to be an organic reason. That doesn't even make sense. Unhung Hero says trash can Jesus does not approve.
Time. and it wasn't CRPS. But actually nailing down the diagnosis, it takes time and lots of observation and lots of hypotheses.
During that period, from September of 2015 to October of 2016, did the records and materials that you reviewed indicate any effort on the part of Drs. Hanna or Cantu or Kirkpatrick to reconcile their diagnosis of CRPS with the diagnoses that were either made or suspected by the physicians at Lurie Children's and Tampa General and All Children's?
Neither Kirkpatrick nor Hanna reviewed the records from Tampa General and Lurie Children's Hospital. As far as we can tell, they certainly didn't make it.
I'm sure they heard what happened from her mother. Gnome, thank you for sending the $20 on Cash App. And it says, thanks for covering the trial. It's a travesty. Well, hopefully there will be some zeros added to a check written by the Johns Hopkins when the jury orders them to. Let's hope for good things.
A note of it in their records. If they had, I think they might have begun to question their diagnosis of CRPS, because what was obvious in those records is that there was something else going on. And to answer your question, no, they didn't pursue any other diagnostic ideas or anything to chase those ideas down.
During the period of her admission to Johns Hopkins All Children's, did it appear to you that there was any change or improvement in the child's condition?
I think there was actually between October and January when she was discharged.
In what respect?
Well, first, certainly her symptoms didn't get any worse, and yet her drug therapy was pruned down from something like 18 medications that she was taking on admission down to a much smaller number. I can't remember exactly what. And that process continued after discharge of slowly dropping off medications that she was taking. She was more functional on discharge than she was on admission. She was able to propel her wheelchair a number of feet. She was able to support her weight standing with assistance. And there were lots of observations in which she was able to do things with her arms, such as reaching for things that she said that she couldn't do, but she was doing by the time of discharge.
Did you see any evidence or suggestion that her stay at All Children's Hospital either caused any aggravation of her condition or caused any injury to her?
No, I did not.
Let me ask you, I'm going to show you, I'll show a couple of pictures here. The jury has heard a lot of discussion, and we've had a lot of discussion about let me back up here and let me ask to show Exhibit 3135-2 in evidence.
Last one.
3135-2. This is a picture of Maya Kowalski, we believe, taken January 1st of 2017. What is the mark on her forehead?
It's a scratch.
Objection, speculation.
Overruled.
It's a scratch.
What are CRPS lesions, Doctor?
Here we go.
There really isn't such a thing as CRPS lesions. There are skin problems that occur with CRPS. The thing is that when there's a skin injury, the lesion or the injury can become larger, it can even form an ulcer because the perfusion, the blood flow to the skin of CRPS is so poor. So nutrients and oxygen are not arriving at the part of the skin that's been damaged, and so it doesn't heal, it just gets worse and worse and worse. So you see small ulcerations, you see very, very large ulcerations, and then there are other, I wouldn't call them lesions, but the appearance of the skin can be very abnormal in CRPS. Very, very swollen. There can be color changes, as I said, deep purple skin. There can be, blood vessel. It's hard to describe, almost like purple stripes on the skin. It can be mottled, but those aren't really lesions. So the lesions that occur because of poor blood flow to the skin, and something injures the skin and it just festers and grows from there. you can see from this picture that, well, a couple of things. First, CRPS does not occur on the face. CRPS type 1, which is what we're talking about, does not occur on the face or the forehead. Number 2, you can see it's nice and pink. It's well perfused. It's got good blood flow. And number 3, it's a linear lesion. It's a fingernail scratch, I would say. I would speculate, but it's a scratch nevertheless. It's not a CRPS lesion.
Let me ask
Which I
that,
just said didn't exist.
that we put up Defense Exhibit 3232-962 in evidence. And for the record, this is, we understand it's dated December 6th of 2014. Now, in this picture, Doctor, this is before the disease, whatever it was, began. How is this picture significant in retrospect?
Well, here we see really a cute little girl smiling, sitting on Santa's lap. She's happy. Obviously, there's not much wrong going on. What I noticed in this picture were the position of her feet. So you see the left foot, she's holding it up. It's at 90 degrees. That's a pretty normal posture. But you know, if you're sitting on somebody's lap or if you're being held up in the air, the feet sort of drop down if you don't pick them up. So her right foot, the foot is sort of dropped down with gravity, and the left foot is normal. But she has to flex her calf muscles to make the left foot go up like that. So the point of this picture is that the very fact that a foot is pointed down like that is not an abnormality.
Okay. Let me ask that we put up 3232-0810 in evidence. And for the record, this is, we understand, dated July 30th, 2015. 3232-0810. There you go. Now, what is the significance of this picture taken shortly before admission to Lurie Children's Hospital?
Can we get the date on the photograph?
That's what I've got is 7/30/15.
I think this picture was taken in Chicago. She's being held by a man. The man's hands are on her left thigh and her buttock. Remember, she could not tolerate the touch of anything on her skin when she was in the emergency room and then in the hospital at Lurie Children's Hospital. She would scream and would not allow anything to touch her skin. But here you see a man holding her, and obviously not only touching her skin, you can see actually the tips of his fingers are indenting the skin a little bit, especially his left hand. And yet she's smiling and happy. And you can see again that her feet are pointed down a little bit, but not very much because they're going down with gravity. And she's wearing socks, and she couldn't tolerate wearing socks or anything on her feet by history at that point in time. But here she is in socks and with somebody touching her skin this way. And of course, her arms, which could not be touched even lightly, are touching his shirt, his shoulder, and her torso is touching his body. And none of that seems to be bothering her. She seems to be very happy.
Okay. Could I ask that we put up 3232-439? And this picture, we understand, is dated July 6th, 2016. What is significant about this picture from your clinical standpoint, Doctor?
July.
Yeah, I don't know why these people can't grasp the concept that it was not all the time, that it came and went. And you don't know how much pain she was putting up with to be hugged by her family and wrestling with her brother. We don't know. Yeah, her condition went worse. It got worse, so they went to the hospital. Thanks, Flux. Exactly.
2016. I'm trying to think of what was going on in her life at that time. 2016. So this was during Hannah's treatment and a couple of months before going to All Children's Hospital. So you see Hannah is in a wheelchair. She's holding her left arm up against gravity. It's not resting upon anything while she's holding her balloons. She's happy. and her feet are both, well, her right foot anyway, is at 90 degrees. It's at a normal position, even though at that point in time, according to Hannah's notes, she had dystonia of both her feet, and then she could not bring them back to a normal position. She had them fixed in a pointed position. We also see that she's, looks like her foot is, her feet are touching the footrest. It's hard to tell. But anyway, that's what I observed in this picture.
Okay. Okay, we then put up Defense Exhibit 3232-354. And that's dated 28 August 2016, August 28, 2016.
Okay, once again, Hannah is in a period of time which is being treated by
Maya? I'm sorry.
Maya is being treated by Dr. Hannah, and he's increasing the dose of ketamine higher and higher and higher because every time she comes in the office, he's recording that
call
she's
her
in terrible
Hannah
pain.
again?
2016.
Okay, once again, Hannah is in a period of
Yeah. Yeah, he's calling her Hannah again.
time which is being treated by
Maya? I'm sorry. 28 August 2016, August 28, 2016.
Okay, once again, Hannah is in a period of time which is being treated by
Maya? I'm sorry.
Maya is being treated by Dr. Hannah, and he's increasing the dose of ketamine higher and higher and higher because every time she comes in the office, he's recording that she's in terrible pain, 9 out of 10 pain. She's got dystonia of her feet, etc. But here we see that she's sitting in a wheelchair. She's happy. She doesn't give the appearance of a child in 9 out of 10 pain, and she has her knees folded, and she's sitting on her feet, and her legs are in contact with each other. You know, the calves are pushing up against the thighs. And again, I would have suspected that that would not be possible for a child with CRPS. That would be too painful.
Now, let me ask, we put up 3232-0345. And this is, we understand, taken August 31st, 2016. What is significant about this photo, Doctor?
Again, this is a time period at which Hannah is treating her, and the dose is still going up higher and higher. So here we see, again, her right arm is being held against gravity. It's not resting on the armrest. And she seems to be comfortable. And her feet are in a perfectly normal position, 90 degrees, flat-footed on the floor.
Her feet are not in a perfectly normal condition. No, they're not. The right foot is turned in. Is he blind?
At a time at which, again, Hannah is recording, presumably because Hannah's being told that her feet are in a fixed dystonic position and she cannot bring them back to 90 degrees.
Okay. And then finally, let me ask you to let's put up 3232-365, which we understand was taken August 18th, 2016.
Dada, don't spoil it. Don't spoil it. Kadada sent a super chat. Thanks for that. Oh my God, Anderson caught him in a lie. We can't wait.
Can you tell us about this picture?
August
16th, 2016.
Okay, again, during Hannah's treatment, this is presumably during one of his treatments. You can see EKG stickers on her chest, a blood pressure cuff on her arm, an IV tubing. You can't tell exactly where the IV is connected to, but there's IV tubing on top of the teddy bear. And she's unconscious. Her mouth is just slack, open, and she's breathing on her own. Presumably, she's pink, and she's not conscious. She's not responsive. This is presumably during a ketamine infusion. Again,
This is so dumb. What can you tell from a photograph of a sleeping kid?
showing that she's more than sedated.
When you say more than sedated, what do you mean?
Well, it's hard to say exactly. Sedation is a continuum from being awake to having your anxiety eliminated, to being lightly sedated, to being deeply sedated. Deeply sedated means she has the appearance of a deeply sedated patient, meaning that she would not respond to voice. But it's hard to tell exactly. She doesn't look like she would.
What? She would not respond to voice? At least she doesn't look like she would in this picture. Oh my God, you guys. I don't respond to voice either when I'm asleep because I'm a deep sleeper. So I don't know what he thinks he can tell from a picture of a sleeping kid, whether she was sedated or not, but come on.
You've expressed a number of opinions here today, Doctor. Have you expressed those opinions within a reasonable degree of medical probability?
Yes, I have.
May I have you smoke me out?
You may.
Yep, the dick defense, they're really going with she was faking the illness. Yep, they really are. They're going with nope, she does not have CRPS. When does Anderson get to cross this clown?
After her discharge at All Children's Hospital?
I've seen Dr. Wassenauer, is that his name pronounced correctly? Her pediatrician. I've seen his records following her admission.
Do you have an impression of how she did following discharge from All Children's?
Back up. What was your question just prior to that?
Overruled on that one.
I'm sorry.
You asked if I had seen records from Hannah, I mean from Maya after her discharge?
Yes, yes, yes.
Yeah, I saw Wassenauer's records. And it seemed like she was doing exceptionally well.
Did it appear to you that she had recovered function in that period of time after discharge?
Yes, she was in high school. She was in athletics. Was doing quite well.
Recognizing that your frame of reference may not extend all the way to the present day, and that you've never examined this patient, do you have any opinion that you can express within reasonable medical probability regarding what future needs she may have?
Well, I don't think she had CRPS to begin with, so I won't comment on if she did have CRPS, what her future needs would be. But I would say, from what I know, I don't see that she would have any particular needs at all, except for support from a mental health professional.
That's all I have. Thank you.
All right, you guys, I just got a comment on yesterday's video that I have to share with you because it's so funny. The mean comments about this doctor, Dollar Store Pee Wee Herman, are unnecessary. He was highly stressed and may be on the autism spectrum. My response was, you must be new here. And for those of you who are new, I apologize now. I look forward to disappointing you. Yeah. If you don't like jokes and you don't like ridicule and you don't like ridiculing bad people when they do bad things, like get up on a stand and lie to hurt someone, or when they colluded with the state to take away a kid from a family, and you don't want me to make fun of their bow tie, you're in the wrong place. You took a wrong turn. I should suggest that you turn around and go back the other way, because this is not your scene. Okay? It's not your scene. Let's go, Anderson. Let's go, Anderson. Let the ridicule begin.
See the attorneys for timing for a second.
Porcelain Thunder. Oh, they just don't understand us, chat. We're just poorly misunderstood. This corner of the internet is not for the weak at heart. Okay?
Let's have you back.
Don't wear a tux to court if you don't want comments.
110.
Like, are you telling me that he looked at himself
Not
in the
discuss this
mirror?
case amongst yourselves. Do not do the investigation and see if
Are you telling me that he looked at himself in the mirror that day? Dollar Store Pee Wee Herman, I'm talking about. He looked at himself in the mirror and he was like, yeah, I'm not going to, nobody's going to mock me for this outfit. Of course they are. Of course they are. All right, hold on. What are we fighting over now?
So you're not objecting? What? She wants to be able to talk to him during.
He's our expert as opposed to
No, he's in the middle of testimony.
So yeah, let's not have the discussion. And is today the day that you're going to have a witness with the diagnosis of Munchausen?
Yes, it is. If you want to talk about it,
we're going to need to talk about that.
Oh boy.
So you can take off.
All right.
Do you want to talk about that now, or do you want to go to lunch and then come back and talk about it right after lunch?
I wouldn't mind a little bit of guidance just because this is going to be over this.
Okay, then everyone can sit down.
Oh boy, we're going to talk about it now. But you know what? Before we talk about that, my legs are getting numb. And you know what that means? It means it's time to do squats.
Do squats!
Yeah, we're going to do some squats. All right, we've got 1 minute and 22 seconds. New people, don't leave. If you leave, I'm going to know it's because you're fat and lazy. So if you want me to believe that you're healthy and you're in good shape and you can do squats for 1 minute and 22 seconds, then you can't leave. Because I'll be back in 1 minute and 22 seconds because we're going to get up out of our seats right now and listen as Nick Rekieta fat shames us into doing some squats. If I can find my video, where the hell did it go? Ah, there it is. Let's go right now.
You impose fatness on you. You did it by going, oh, I want the butter on the popcorn. Oh, I want the butter on the ice cream. Oh, I want the butter on the sandwich. Oh, I want the butter on the salad. Stop eating butter. Can you just get up, walk 1 mile?
To squat!
Walk farther. And if you can't walk, crawl, roll, get dragged by a goddamn forklift. Whatever is wrong with you, just move. Ever. Get off the chair. Get off the couch. No one is coming to service you while you sink into that furniture, while you become one with the pleather your poor ass got on that Walmart couch. Can you try not floating into sadness? Stop eating, stop drinking, start walking, start doing anything that you haven't been doing, you fat piece of shit.
All right. Your blood should be moving by now. Hey, we lost 10 people. We always lose people.
Unacceptable.
I don't understand why you people can't do a couple of squats for 1 minute and 22 seconds. I didn't even have the volume boosted, so it couldn't have been that loud. All right. Going back to the fighting in the courtroom. Wait, where's the sound?
Sure. So the witness after Dr. Crane will be Dr. Paula Dees. She's a pediatric hospitalist who saw the patient over 2 1-week period.
Oh, great. Paula Dees. She's the one who was on the text messages. Yeah. She's probably going to have to go in the munchie bunch.
I believe roughly starting October 18th for about a week, and then again on October 31st for about a week. Her notes are significant that in her initial impression and plan, she does have as one of her impressions Munchausen by proxy. I think it's her exact words are concerns for Munchausen by proxy. And then there's obviously discussions in some of her progress notes about DCF. You know, one particular one, Mr. Kowalski is asking, or Maya's asking to visit with her father, and she says she contacted the Child Protective Investigation CPI to help coordinate that visit. I don't know that that's as much of a concern since I'm not going to dwell on it, but I'd appreciate the court's guidance in terms of what you want me to do there, and specifically whether they're going to cross-run.
Well, I'm sorry. So I thought you were having a expert
My
come
apologies.
in.
No, our expert that would have qualifications to touch on Munchausen's would be Dr. Alexander, and he's not coming until, I believe, Monday or Tuesday next week. So this is just a hospitalist with that concern for Munchausen as one of her diagnoses in a record.
Well, let me, because I meant to say this yesterday and then again this morning, but I am, this is kind of where I'm at right this second. Whether Beata Kowalski.
I'm sorry, Judge. I'm stopping you only to.
Don't
throw this
interrupt
out
the judge.
Because I've got Sally Smith coming in 2 days.
Oh,
So
boy.
if you can give us the benefit of your wisdom on both these points, it would be helpful.
In my view, whether Beata Kowalski in fact suffered or had
How many
Munchausen
times does he
by
have to tell you
proxy,
this?
I don't see how that is material to any cause of action or issue that is remaining in this case. So I'm not sure why we need to be trying to prove
All
the
of
diagnosis.
these nuts. Thank
Now,
you, Unhung Hero.
The observations of the hospital, its doctors, that, you know, as Maya was brought in and what the situation that the hospital faced with Maya coming into the hospital, I do think it's relevant to help explain how and why the hospital made the decisions that it did. So, I mean, that's why I've been letting in, you know, the Lurie, all of these prior hospital visits. But when we get to, I'm not sure we need a witness to come in and testify that mom had Munchausen by proxy. I don't see what we're asking the jury to decide in this case, as opposed to what would have been the Chapter 39 case. So that's kind of where I'm at. Now, your specific question about Dr. Dees. I mean, she's a hospitalist. I think she was a hospitalist.
Yes, Your Honor.
And so, I mean, her observations, I think, are fine. And I'm assuming those records are in evidence that you were referring to.
Yes, Your Honor.
Now, again, the gravity associated with the Chapter 39 proceeding tends to pull everything, but let's avoid the temptation to be pulled by the gravity to walk down the Chapter 39 issues.
Yeah, and so just for some clarification, one of the issues in the case that the plaintiffs have been attacking, so well, I'll just cut to the chase. On the transfer forms to Nemours in late October, November, not the first one before the shelter order, but later, the Nemours documentation says, I don't know if it's exactly diagnosis, but they have diagnoses codes for several conditions. One of them is Munchausen's, and it says, quote, assigned by Dr. Dees. The plaintiff in this case has made a central issue that the reason why the Kowalskis would not agree to the transfer is because they didn't agree with the transfer codes. So I would appreciate some guidance either from the court or from the plaintiff. Do they plan on trying to cross-examine her? I feel like she would need a chance to explain some part of this if they're going to cross-examine her and make an issue to the jury that she had no right to list that as a concern, and that her thoughts on this were the reasons for blocking the diagnosis. It starts to make that, in her words, a concern, in blocking transfer of material issue.
Well, I suggest that the witness stay away from the transfer issue to avoid this. The fact is that there were no doctors qualified in any way, shape, or form at the time of the Nemours or before at Johns Hopkins that diagnosed Munchausen by proxy. It came from a nurse, Ashley Sumner. And to a certain extent, I think Dr. Malik, the record reflects. And so to the extent that they presented this to Beata and Jack Kowalski with diagnostic codes for psychological issues, then that is relevant material to their decision not to sign the transfer. But I prefer not to get into the Munchausen.
Well, because there were two transfers. What time are we talking about?
Yeah, I think the actual time of the Nemours record for transfer is November 2nd.
But at that point, that's in Chapter 39 timeframe, and that was an issue that was being discussed in the dependency court, right?
Yes.
Right. November 2nd, there's transfer efforts were availing for some period of time. The initial transfer effort, the one that we heard about this morning.
The one in October.
Correct. Yes, sir. That one is 39 neutral. There was no petition. There was no order.
Can I just stop you there? But is that the one that Dr. Dees is going to be talking about?
Yes, and to your point.
And not the November one?
Correct. She was not, no, the other way around. She was not involved at all until October 18th. She had no involvement in the first one prior to the shelter. Her only involvement was trying to get, as one of the members of the medical team, trying to get the kid transferred to Nemours after the period of shelter. And the plaintiff has attacked Dr.
Whitney is
Dees
so ready.
and All Children's for
He's so ready to
including
jump in.
or
Look at
having
him.
some influence on the diagnoses codes
like, when's it my
being
turn?
Munchausen by proxy as the reason why they would not sign on to transfer.
On that particular issue, I go back to whether you prove that mom had Munchausen or not. It doesn't go to Beata's state of mind as to why she wasn't going to sign it.
Right, but
I mean, one, it seems like that specific time frame is when the dependency court was involved in addressing this particular issue. And so I'm not seeing how we really need to walk this path with the November transfer attempt.
Let me try to articulate this in 30 seconds just to give you my frame of mind.
Why do we
The
have to
concern from the defense on a
continually
more
hear from the
overall
defense?
basis is from opening argument and at various points of the trial, the plaintiff has injected into this litigation, right or wrong, and sometimes over the judicial instruction, that the only way Maya could be freed from All Children's was for this sort of altruistic suicide, right? And I know that obviously goes to some of the elements of intentional infliction, and they're arguing directly in opening that
All right, hold on. Nick has a very important question that came in with a super chat. What should be the Instapot meal I buy groceries for? Because that's more valuable than whatever Shapiro quacks. All right, let's think. Have you made cracked chicken? Because cracked chicken's pretty good. You serve it on like rolls, and it's like chicken and cream cheese and bacon, and I forget what else. But just search it on online. You'll find it. It's called cracked chicken. Also, I like to make pasta in the Instant Pot. Do you know about this? You can put a pound of pasta in, and then, well, no, sorry. First, you brown some ground beef in the bottom, on the saute portion, and season it with Italian seasonings. Then pour a box of pasta on top of that, and then chicken broth and a can of like spaghetti sauce or whatever, tomato sauce or some kind of tomato sauce, and just cover the noodles with the liquid and the tomatoes. Just cover them. And then you cook that for like 12 minutes, and then it's perfect. You mix it all together and it's like a yummy Italian pasta spaghetti sort of meal. But I use like the curlicue noodles or shells or something like that. And I also at the end will stir in some cheese. So good. So good. I don't know what I'm doing for dinner, but now you've got me thinking about it. I'm gonna have to think.
Because we accused Beata Kowalski of this Munchausen's diagnosis, so we believe it's material for that. And it's also one of the defenses to their themes of the only way to free Maya was this altruistic suicide, is that we were actually trying to actively transfer her throughout this whole time, to which the plaintiff's response is, yes, but only with this erroneous diagnosis code, which they would never agree to. So while I completely understand the court's point that in general, whether Munchausen or not Munchausen isn't directly central to any themes, the plaintiff has made an argument, and my fear on the defense side is they're going to stand up in closing argument and say, we couldn't get Maya out of there because they made this diagnosis of Munchausen with no basis, and we're afraid we're going to hear it in closing.
Well, I mean, you probably saw the instruction that we were discussing this morning, where I'm specifically saying, and I think I had took the language of Mr. Altenburn about how the hospital is not responsible for the length of the stay of Maya in Johns Hopkins, because only the dependency court control that issue. So when we talk about a transfer that is during the dependency action, as opposed to the attempted transfer when there was no shelter petition filed and no dependency court involvement, and we have the prospect of a false imprisonment, I see those as materially distinct issues. And so how do we get to discussing that specific transfer attempt in November without getting into what was going on in the dependency court? That's that gravity of the Chapter 39 issue that I'm trying to keep us from going into this black hole.
I'm completely sympathetic to this court's position on that, and you're absolutely right. That is an issue that bleeds together, if not as a gravitational pull. Again, this may be an issue for a jury instruction, where we are going to likely request an instruction that the plaintiffs are not seeking damage from the defendants for any allegation of Munchausen, that the plaintiffs are not going to suggest to this jury that some allegation of Munchausen caused or contributed to damage. But I guess we can deal with that. But I guess for the very short purpose of this witness, what I think I'm understanding from this court is, while they're certainly going to see that in her record, and we can touch briefly on the fact that that was part of her impression, that I will not have this witness focus on the Munchausens, although, again, I'm somewhat concerned that they're going to get into with this witness. You worked with, you consulted with Sally Smith.
Oh, here we go.
They're going to blow the door open to this, right? So
Well, Mr. Whitney, Ms. Lawrence, and Mr. Anderson are hearing this discussion, and all I would say is, if somebody feels they're going to be asking a question that might draw us into that vortex that is Chapter 39, and we can't escape the pull of the black hole that is Chapter 39, come talk to me ahead of time before we ask the question.
Yes, sir.
Okay. Now, Mr. Hunter talked about Sally Smith. That's probably a longer discussion than a couple minutes before we run to lunch. But as a 30,000-foot view, it seems to me that you can talk, and Dr. Sally Smith can, generally say what she was doing, not that what her specific diagnosis or recommendations were, but she came in, she's talked to people and whatnot. She was on staff, that she also had this second hat, which is with the Suncoast and whatever her outfit is in her contracts, but very generally about that, but not into the specifics as to what her recommendations were. And I think you also are able to talk about saying, hey, the plaintiffs are saying that you were on staff and that you were treating her. These are some examples of what the plaintiff was saying that you were treating her with, and then getting her to say whatever she's going to say about that. But I don't want to get into a really lengthy discussion about the 14,000 things she did or didn't do as an investigator in the Chapter 39 proceeding. Does that help any?
I think so. The big question is, I guess, and I think I just heard the answer, that you don't want me walking her through her report.
No,
No.
we're not walking through.
The
through
report doesn't come
report. I
in.
mean, I've kept that out.
Oh my God, Hunter. What it's but how could you walk her through the report when he has already denied that report to come into evidence like twice already? Of course you can't walk her through the report. What is there nothing that this dick defense will not try?
That over, and I may ask for the guidance.
But I believe, since the plaintiffs have put into play the concept that Sally Smith went over her line of demarcation as an investigator and was treating Maya, you are able to defend the allegations that she was treating Maya.
Yep.
I mean, I think that is fair, and you're allowed to defend that against that allegation.
Okay, thank you, Jen.
He is not
We were back
happy.
at 1 o'clock with 10 minutes before the jury
He
comes
is
back. Is that enough
really
time? That gives us an hour and 5 minutes
unhappy.
before.
He does not like it when the judge tells him what he will and will not do. Hunter, by the way, I have discovered, oh, by the way, you guys, on Friday night, I'm going to be reading through a court transcript with several of my friends, including Legal Vices. Flux will be there. I've invited Valhalla, Awaits, Chandler Remington. We are going to do a dramatic reading of one of the dependency hearings in the Maya Kowalski case. One of you sent me the transcripts from one of these things. It's going to make you really mad, but it has to be done. We have to see what happened in the underlying case. These things hardly ever come to the surface, dependency hearings. They're always sealed from the public. So when we get a chance to see one, we really need to see it. We need to hear it. So I'm going to broadcast it. Will there be wigs? No wigs. I think in this case, it's not depth sidebars where it's all very hilarious. And I don't think we'll be doing any voices because the topic itself is just so awful. And Beata Kowalski actually is a witness in this hearing. So we'll be reading the words of Maya's mom, who is no longer here. So I think we're going to take it a little more seriously. No puppets this time. But it needs to be done. Mr. Hunter, by the way, and that's why I was thinking of this, Mr. Hunter is in this transcript. He has been defending this hospital since they did what they did to Maya. He was the one in the dependency court fighting against the Kowalskis. And frankly, I am shocked that he is the lawyer that they have doing this case because he obviously cannot separate himself from the dependency action because he's been a part of it for so long. And he keeps stepping in it and angering the judge because he wants to bring in all this stuff that he knows about the dependency case because he was there. But this is a different case. So tune in for that on Friday night. I believe we're doing it at 8 p.m. If I get the I need to hear back from Valhalla and who else am I waiting to hear back from? I think just him. So we'll see. I think it's going to be Friday night at 8 p.m. Eastern Standard Time.
Never you're able to play it.
Okay, so that's 3085-1. Make sure the volume's up, please. That's it.
What does that prove?
Background static. So I'm assuming the sound was on and there just no one was saying anything.
What
Any
is that
objections to
prove?
that clip?
No objection.
What in the
What was
world?
the number again?
30851.
What did we
Dash
see
one.
there?
Court
objection.
I'm sorry. I got to go back and look at that again. There's a nurse laying in bed, moving
That's
her
it,
head around. Okay.
What was the number again?
30851. Thank you, Jen.
It just makes me sad and mad.
We had a discussion with regard to the demonstrative aid, as I understand it, that plaintiffs wish to use, and we are not objecting to the use of it as a demonstrative aid.
This one, we can get one for the court, I hope. We have an extra one. Judge, do you want this? You can bring it up.
Does it have the word Sally Smith on it?
No.
No Sally Smith.
But it does have bunch houses, okay.
What?
What?
It's got a t-shirt that says.
He's messing with us, guys.
It's 805.
Hope the jury's not red, green, colorblind.
1085.
What's next?
I don't know, Judge. I don't think there's anything that can be handled in 2 minutes and that needs to be dealt with for this witness.
From a timing standpoint, when is the defense anticipating they're going to be able to rest?
Judge, can we tell you that tomorrow, only because we're going to meet tonight and kind of go over everything and make sure what we've got lined up is and
I
what
would
we
really
do or
like
do
to know
not need
that.
to absolutely do. If that's all right with the court, let me put it this way, we'll be more accurate if we address that in the morning.
Okay. And I guess my overall hope, request, thought, really we kind of need is all evidence, including any sort of rebuttal case, to be completed and all exhibits in by next Wednesday, November 1st.
We don't see that as being an issue, Judge.
And my thought again is if we're resting on next Wednesday, remember Thursday and Friday, I will not be here. And then so my thought was we would do jury instructions and closing arguments on Monday, November 6th, and then start deliberations the morning of the 7th, Tuesday the 7th. You got a facial expression there, Mr. Hunter. I'm trying to read what that facial expression
No,
meant.
I mean, I looked at the calendar too. We need to talk about it, but tentatively, I don't see an issue with that. The reason I made a face was I was kind of thinking, start deliberations on the 6th after closing, but that's just.
We can talk about it. I mean, I think each side could put 2 hours for closing and then the amount of time for court to read the jury instructions. And since I read very fast, I know I read very slow.
We need to assemble a booklet too.
We're working on that. Okay. Can I bring the jury in, or are there any other issues?
Oh, Judge, just briefly, we have requested the plaintiff to provide us with their list of all the exhibits that they have put in, and sensing some resistance to that idea. We just want to have their list. We want to work on this Excel thing that the court has requested. And so it'd be helpful for us to have their list of what they have admitted.
Do we have the list of text messages?
Yeah.
We can provide it this evening. Fantastic. I'm getting a request from the clerk's office. They would really like to see a copy of it as well, even if it's just in draft. So
We will print the copy and make one.
if you probably want two. Thank you. Anything else before I bring in the jury?
No, not on behalf of us, Judge, sorry.
No, you're.
Let's bring in the jury. Yes, please. So is that monitor working?
So apparently, Jeff, Legal Vices is sleep modding. Did you hide someone, Jeff? What did Chaos do? Why are you modding in your sleep? Do we need to apologize to Chaos?
Okay, please be seated.
I don't know. I don't know
I
what's
know that we
happening.
need to make
It's-
sure that, no, don't tell us
It's
publicly
a
where
shit
you went.
show.
Send
Jeff-
us the note.
Jeff may
I'm
have
sorry to
just
hear that.
he may have just rolled over on his phone.
You had a good lunch? Okay.
Oh, he's back.
I mean, I know the
Chaos
county has
coordinator
not
is back.
provided you lunch at all throughout this entire process.
All right, you're
so.
back.
In any event, I just want to confirm while you're away, you did not discuss this case amongst yourselves. You did no investigation and received no information. Is that all correct? And that you have not seen any media accounts of this case. Is that correct? And no one has approached you about this case. Is that
I was
correct?
going to say, that doesn't sound like something Jeff would do.
Doctor, you remember you're still under oath. I do.
He must have just rolled over on his phone.
Plants?
He fell asleep listening.
Dr. Crane, how much have you been paid so far for your testimony?
I don't have a running total in my mind. I'm sorry.
Well, is it over $100,000?
No.
Is it over $50,000?
No.
How much do you get paid per hour for testifying in court?
$750
An hour,
an hour,
including prep time,
including prep time.
including travel time?
No.
What's that?
$300 an hour.
Okay. Would it be safe to say that you're between $25,000 and $50,000 being paid now or in the future for your testimony?
Not to date. It's been less than that to date. I don't know how much it will be after
I
this
will
week.
say that I don't think that these questions for experts are, I don't think they're effective. Everybody knows that experts are paid, and I don't think it works for either side. And I think Anderson really needs to just move along because he's running out of time. He's got 8 hours left. Move it along, Greg.
Okay. And so how long did you spend total with counsel in the, say, month prior to your testimony?
2 hours last night, and there have been some phone calls over the last month.
Well,
Maybe about 3 or 4 hours of phone calls.
Before your report was issued, though, you spent considerable amounts of time with counsel, did you not?
Before the report was issued, which report? I don't know what you mean, Mr. Anderson.
You had done a report in this case back in 2021, I believe.
Oh, that. Yes.
You did, right?
Yeah, I don't know what you mean by considerable amount of time.
Over 10.
I also don't think spending time with counsel, I don't think how much time he spent with the opposing counsel means anything either. Get to the real questions.
I provided you my billing records to date, and I don't remember the details of them, but you have them in front of you, I think.
Okay. Is gastroparesis a symptom of CRPS?
No.
Best of your knowledge. Okay. All right. So you had testified first. Let's talk about Dr. Hanna. You had testified that you felt that Dr. Hanna's treatments did not work, right?
Correct.
And that was because, and one of the reasons for all the weaning was because the dosage just kept going up and up and up. Is that right?
Yes. That's
okay.
correct.
Oh, and incidentally, there's nothing wrong with being paid by the hour, is there?
No, of course not.
No. That's $750 an hour. Just checking on something. All right. So you said it had been going up and up and up, and that's as to the dosages. Now, is that the individual dosages?
I'm not sure what you mean by that.
Well, the per infusion dosage.
The total over 4 hours has gone up, and the hourly rate of infusion has gone up.
Okay. So how many infusions, what was the infusion rate in June?
Can I look at my notes? I can tell you if I look at
Sure.
my notes. Okay, they're in my briefcase. May I get them?
Sure.
We put the notes, right? Yeah, we put the progress up in hand, so.
Sure. We've got the progress note if that helps you.
There's going to be a monitor here, sir.
Okay.
Put it on the monitor.
Okay, if I can look at I have some notes with the details. There's a lot of details, and I don't want to be incorrect in answering the question.
If you have notes, I'd like to mark those, Your Honor, right now for as an exhibit, or actually for identification right now.
Do you want them? Or
Yeah,
should
I
I just
haven't
read
seen
off
them unless you got a spare copy, but you
I
can
do
use
not.
them right now.
I do not.
Sure. All right. So we've got Dr. Hanna's progress reports here, and I believe it shows over 4 hours, 1,000 milligrams.
Which date are we talking about, please?
Well, in this instance, it would be for the month of June.
I have the dates on specific, the amounts on specific dates. I don't know what the monthly total would be.
Okay. Well, is it true that on every single day between between March and August of 2016, the same dose was used, 1,000 milligrams?
Yes, and then it's September 30th, the dose began to rise.
All right. Well, we'll get to that in a moment. The most it ever went to was 1,250 by your records, correct?
1290, I think.
And so up until October, it stayed at 1,000 milligrams.
That's right.
All right. So then it
I'm
did
going
not
to make
go up
lunch.
through the
I'll be
course
right
of the
back.
summer, did it? Unless, of course, the number overall of infusions went up, right?
It went on September 30th. It went up to 1,200 milligrams, but you're correct that it was 1,000 through that part of the year.
All right. So if the jury got that impression that it was actually going up from your testimony over that entire period of time, that would not be true.
I apologize for that. I misremembered that.
Okay. And so the number of infusions, it was your testimony that they kept going up and up and up, isn't it?
No, I don't think I said the number was going
Okay.
up.
Well, how many infusions were there in March 2016?
I'd have to look at his records to count them. I don't remember that in that detail.
All right. I'll just list them out. You tell me if you have any notes for any one of them, and then we'll see what we can do. March, do you know how many?
I think I just said I don't know how many.
All right. April, May,
Well, I didn't. If we can look at Hannah's records, we
June.
can answer that. But I didn't record the dates of every single.
might be able to
infusion.
help you. Can we put up the summary? Doctor, I'll represent to you that this is a summary agreed to by the parties. And if we can go to 2016, please.
I just found out that my dad is listening. Hey, Dad, how are you? My dad and my sister are listening together. Hi, Dad. Hi, Steph. glad to hear from you. They're trying to figure out how to send a tip. Those of you who don't know how to send a tip, like my dad, uh, you can, Dad, you can just PayPal me. Mom has it on speed dial, I think. But you can do Cash App, you can do Venmo, you can send a super chat. And the way to do it is to go down to where the comments are, Dad, and you see the little money sign. So if you're on Rumble, it looks like this. And if you're on YouTube, I think it looks similarly. And you just hit the little dollar sign, and it connects to your Apple Pay account or Google Pay or whatever. I don't know. But if you want to do that, go ahead. Yeah, do. Dad boomered the tip. Well, he's trying to figure it out. He wants to send a super chat. Okay. Dad wants to send a super chat. So Dad, you need to go down to the comments and click on the little money sign. And then you're going to fill in what you want to send. And then you write a message. Write a message there. And then you hit send. All right. Let's go back to this. Love you, Dad. On Rumble, it's the same way. Yeah, it's the same on Rumble. You go to the little dollar sign, but I think you have to be on a browser to do it. I'm not sure on Rumble. My Rumble peeps could answer that, although they're really bad at sending rants lately. They haven't. So I don't know if any of them in there know how, because they sure haven't shown me that they know how in the last couple of weeks. But that's okay, Rumble. I love you anyway. We believe in you, Dad. We think you can do it. Been there, done that says, let's see how much Dad is going to send. We're going to see how much he loves you. 6079 Smith says, just like this, Dad. See, there's a $2 super chat. Thank you so much. Chicago Jan says, hi, Megan's family. How's Mom doing today, Dad? Why don't you super chat me and let me know how she's doing? I hope she's doing better. Better than she was. All right, here we go. I gotta go get a snack.
Its use was agreed to by the parties. The summary is agreed to by the parties.
Well, the numbers, I believe, are agreed to. The summary itself developed, but these are the numbers agreed to. All right. So if you look at the infusions then in March of 2016, there were how many? 17. I counted up. That look right to you?
Are the greens? Oh, I see. Greens are
Yes, sir.
infusions. I'll take your word for it without counting.
All right. In April, there were 5. May, 3. June, 5. Does that sound right? July, 4. August, 3.
Wait.
September.
I know it's a small thing, but can you say yes?
Jenna says, I am so hoping that his super chat message says, nobody gives a shit about your hair. Oh, Stephanie, if Dad is going to try and if he's going to send a $150 tip, please send it on Venmo or Cash App, because if you send it on YouTube, they're going to take half of it. You don't want to give Google Dad's money. Send it on Cash App. Send it on Venmo. Don't you have Venmo or PayPal? Oh my God, don't send 150 on YouTube, because they're going to take most of it. God, we may spend the next 30 minutes talking my dad through how to send me money. Stephanie says we will not do YouTube. Yeah, tell Dad it's like a tax, they tax me. And I know how he feels about taxes. Rumble is better. If you can send it on Rumble, that would be great, because they're giving us 100% of our tips until January. So woohoo! Woohoo! 100% of our tips on Rumble right now.
Yes, of course. Yes, of course. Yes to all those previous questions.
And September, 4. Is that right?
That's right.
All right. So through this period of time, in fact, the number was not increasing. The highest one was March. Correct?
Correct. The number in March, yes.
All right. So if we take the number of infusions and the fact that they weren't increasing, and the amount of the infusions, and they weren't increasing at least until October for 3 times, you would agree with me that you were wrong in saying that Dr. Hannah's infusions were going up through the course of spring and summer.
I was incorrect. Yes, I misremembered the infusions going up in dose. They were stable at 1,000 until September 29th.
Okay. Well, you've known about this case for at least 3.5 years, have you not?
Yes, I have.
Have you ever actually spoken to Maya Kowalski?
Of course not, no.
And have you ever examined her?
No, I haven't.
Nope.
So you don't know whether she has testified under oath here that these treatments were the only thing that helped her.
Objection to
Do
asking
you?
one witness to comment on the testimony of another.
This is a very good suggestion, Kim A. Send a $1 super chat where you can type your message and $149 on Venmo. Not a bad idea. But don't worry, guys. Wherever he sends it, I will screenshot it and share it with you guys. I promise.
Would you repeat the question, please?
Are you aware, or are you not aware that Maya Kowalski has testified that the only thing that helped her pain were these infusions?
If she's testified to that, I'm sure that she did, but am I aware of it? No, I wasn't aware of it.
And doctor, isn't the ultimate goal here to help the patient?
The ultimate goal is to improve function and diminish pain.
Which is helping the patient,
That's
right?
Yes, I wanted to be more specific than just using the word helping.
And the main thing that Maya Kowalski.
Wow. Dad says he's going the old-fashioned way and sending it to you in the mail. But he wants to inspire all your other viewers to give big tips, and he will match what they give up to $150. Aw, thanks, Dad. So I have to keep track, and then I tell Dad how much he has to pay. Is that so? He's basically betting that you guys will not send $150, and he won't have to. Is that it? Is that the plan? I see through it. I love you, Dad. I was just kidding.
Kowalski complained about was pain, was it not?
And loss of function.
All right. And so through the course of the spring and summer, as the dosages from Dr. Hannah were going on, did anybody ever show you any of the videos of how Maya Kowalski's function improved?
I only saw one video of her, and I don't remember the date, and that was of her dancing on her bed, but I don't recall when that figured into the chronology.
Did you see any of Maya and her brother in the pool?
No.
Did you see any of Maya on a walker on its side, using that as sort of a exercise bar?
No.
Eat it and weep,
So,
Dad. We're big spenders
If
here.
I'm understanding
$5
your
now.
testimony then,
We're $5 in.
the thing that people did wrong here was that they did not follow your clinic's program. Is
Jojo.
that right?
Jojo for the $50. Oh my God. Been there, done that. Jojo sent 50 and been there, done that. Just sent 20. Good job. Get your wallet out, Dad. Jojo says, try us. You guys are so funny. Yeah, guys, if you're having trouble with the unbanning or the banning, I don't know which mods can do that. We don't ban people here very often. So yeah, David says Megan makes medium wage here. That's right, medium wage. That's all we're going for. We're going for medium wage, not minimum wage, but medium wage is good. Thanks, guys. Get your wallet ready, Dad.
Absolutely.
Okay.
All right,
but
let's
you
back that
did
up. I
not
didn't hear
follow-
that question.
The thing that people did wrong here was that they did not follow your clinic's program.
No.
Is that right?
Absolutely not.
That's what it
Okay,
sounded
but
like.
you felt it.
That's what it sounded like. That's what you testified to.
Physical?
You remember you testified that you're Jesus Christ of the pain clinics. You don't remember testifying that you walk on water and you heal the sick everywhere you go? That every 10-year-old little girl with CRPS has walked out of your clinic healed? That they've danced out? Because that's what you testified to.
Physical therapy, occupational therapy, CBT, cognitive behavioral therapy. These are the cornerstones, right?
Well, I didn't say CBT. That's just one form of cognitive. That's just one form of psychotherapy, and it's more complicated than just to use one form. But I said that those were the cornerstones, the foundation of treatment of CRPS, and that's something which is nationally, if not internationally, recognized.
Did you go through the records of Tampa General Hospital and see what she received over the course of 1 month inpatient during the summer of 2015?
Yes, I did.
And did she have physical therapy?
Yes, she did.
Did she have psychological therapy?
She had some, yes.
Did she have occupational therapy?
Yes, she did.
Yes, she did. She had
And
all
she
of
had
these
that
things.
for a month, right?
Correct. That's right.
And at the end, the physical therapist said she wasn't improving, right?
The PMNR doctor, the rehabilitation doctor, felt that she was ready for discharge and to continue the same therapy as an outpatient. In other words, she no longer required inpatient hospital admission. And these things are generally done as outpatients.
Got it. Did you?
All right, Scrooter McBoogerballs. Scrooter McBoogerballs. Let's see. Nothing. I just got a PayPal from Scrody McBoogerballs. Nothing to say, but get out the checkbook, Dad. I got another $5 on PayPal. So what are we up to now since Dad made that that challenge? That's $75, $80. We're at $80. We're at 80. He says he's matching up to 200. Oh, Janet just sent a $20 in. Thanks, Janet. Make a believer out of Dad. We're at 100. Woohoo.
Or did you not tell the jury on direct examination that under your approach, especially for a 10-year-old girl, you know, when their mind is developing, that your program here could work in a matter of weeks?
I said in a matter of weeks, but not 4 weeks, and 4 weeks is never enough.
So now it's more than 4 weeks you need.
I said weeks, and generally our program lasts for 6 to 12, sometimes more. But I would say 10 weeks is about the average for CRPS.
For the people that were there actually seeing Maya Kowalski as she left Tampa General Hospital, she had not improved after 4 weeks of the therapy that you advised.
Stephanie, Dad says your viewers are cheap. He says there's a time limit on this. What's the time limit? That is so like my dad. He's an Indian giver. He will dangle something out there and then he'll be like, you didn't do it fast enough, so you're not getting it. You're not getting it. He offered me $10,000 to run away and get married so he didn't have to pay for a wedding. And then when my husband and I were like, okay, we'll do that. We're going to go to Vegas or something. I'll have the $10,000. He was like, I never said that. And then he paid for a wedding that was way more than that. Ben says, I'm cheap. How dare you, sir? Oh, I'm glad we're making his day. Oh, that's good. I didn't realize he hasn't watched for a long time. I feel like he hasn't been in the audience. I like listening to Dad roast the audience, though. That's fun. Tell him to keep it coming. The insults are great. Porcelain Thunder, language, Native American bestower. 6079 Smith sends a $5 super chat. Can't change the rules in the middle of the game, Dad. We're at 105. 105. Dad says no more $5 tips. Let's see the 50s. I need to make Dad a regular part of this show. Janet says, send a $2 tip. Dad, you have to state those terms prior to making the rules. I agree. He never does, though. He always goes back on what he said he was going to do. If you guys hit 200, he'll be like, well, they were 5 minutes late. Clearly, Dad is needed here. Mm-hmm. Yep, he needs to be a part of the show because he's the only one raking in any dollars.
Eyes would work. True.
Let me just check my notes after this.
Wait, what was the question? Stephanie says, don't these people have dads? This is how they operate. Stephanie, I really don't think everybody's dad does what our dad does with the changing of the goalposts constantly. Yes, Sheila, he's changing the goalposts.
Sometimes more, but I would say 10 weeks is about the average for CRPS.
For the people that were there actually seeing Maya Kowalski as she left Tampa General Hospital, she had not improved after 4 weeks of the therapy that you advised would work. True?
Let me just check my notes out, please. Well, I'll answer your question in the following way. She wasn't performing significantly better at physical therapy, but she was doing things when she wasn't aware of being observed or when her mother wasn't in her presence that indicated that, in fact, there were physical improvements in her behavior and in her appearance.
You got that from Bonnie Rice, correct?
No, I did not. I'm pulling that from the Tampa General.
Stephanie says, if you get your audience to give more than 200, I'm going to get Dad to give you an extra bonus. Good luck on that. It's like squeezing water from a stone. I'm just kidding. My dad is super generous. This guy, by the way, he just said, if you were listening to this between the hilarity, Oh, you need a photo with dad in the cash register that makes the cha-ching noise for every super chat. That would be hysterical. I need that. I need that. I need to make that. You know, I was looking the other day for my video of him because I made this video of him complaining about my hair. In fact, you guys, I have to play it because those of you who are new, you got to get to know my dad a little. Now that he's made himself and he's made an appearance in my chat, you guys have to get to know my dad a little bit. And some of you haven't seen this video, and it gives me 4 minutes to go do what I said I was going to do, which is get something to eat because I've been sitting here with no food. So let me search. It's my dad tells me what's wrong with my channel. Where is it? Here it is. All right. Dad tells me what's wrong, what I'm doing wrong, which is what he's really good at. Hold on. I'm going to play this for you while I go and get lunch. Don't leave. Don't go anywhere. You're going to get to know my dad a little, and he is a scream. You're going to love him. And you're going to like this. It's a bop.
I wanna see you,
Tell me all about what I'm doing wrong.
You can't be talking about your hair.
Mischievous. I miss your curly hair. So of course, for the rest of the day, it's just gonna be people fighting between the straight hair and the curly hair. I can feel it.
You can't be talking about your hair.
Glenn says I need smaller glasses with my hair straight. Okay, look.
Well, you gotta get controversial.
With me today is the lovely and wonderful Megan Fox. Not that
Hey,
one.
not that one.
Was he queer or what?
Well, I'm medium good looking, you know.
You're medium attractive.
I can live with that. I can live with that.
You can't be talking about your hair.
Did you
And
get
I
my...
really like your hair like this. I really do. It's fantastic.
Is he queer?
It's pretty blonde.
It's pretty blonde.
It's very blonde. It's a different style. I mean, I kind of noticed the color, but it's mostly just the styling. That,
Oh, just because
that I
it's
noticed.
straight.
Is he queer?
What?
You can't be talking about your hair.
Yeah.
I have wavy hair naturally, so I don't straighten it very often. But it's a whole thing.
You can't be talking about your hair.
That's okay. I just don't even have hair back there.
You can't be talking about your hair.
It's all just a front.
Is he queer?
What? It's the weirdest bald spot ever.
You can't be talking about your hair.
Tim has a full head of hair under that beanie, Megan.
Is he queer?
No! This is terrible.
Is he queer?
Okay, that's enough of that.
Is he queer?
Nick's gay lover says, rate Nick's female guests. Okay, that's enough of that.
That ain't get it.
And this is the base color that covers up the grays. And then I get my highlights put in after that.
You can't be talking about your hair.
Okay, Tech News says you should go blonde.
What?
I had to get my grays covered up. I don't like my hair dark like this.
This is terrible.
That ain't get it.
I identify as a blonde. I was born as a blonde. I will probably never be this blonde again, though.
It's pretty blonde.
It's pretty blonde.
It's very blonde.
This color is so much maintenance. Probably a little lighter than this naturally.
You have no chance.
It's hard to get the right color. When I go all gray, I will totally be able to go back to that color.
You have to get to your subject a little sooner. Yeah, a little sooner. I lasted for 10 minutes. I had to get up and pee. I couldn't even wait for the rest of it.
Right now, I just have gray around the edges. Like, there's not a whole lot of it anywhere else. So I would still have to use bleach, which is so damaging. I make these weird faces like I'm in pain when I squish my hair, and I don't know why I do that.
You have no chance.
But I tried stopping it, but it's almost like the mascara face. It can't be stopped.
This is the kind of stuff you should have on YouTube.
I will be doing this for an hour. And it
Yes, I said it's enough. I don't care about her hair.
will be like a good hour. Like, I'll be planning my day and figuring out what am I going to write today.
What a lot of crap.
But I want to talk about Carrie's hair.
Yes, I said it's enough. I don't care about her hair.
And as a curly girl myself, we don't have very many curly girls out there who are, you know, kicking it for the girls with waves and curls.
You can't be talking about your hair.
When you slick it back like that, you destroy the curl.
What a lot of crap.
This is Carrie Bradshaw. This is what her hair looks like. Do you remember how iconic and beautiful and glamorous this was? It doesn't make sense for Carrie, the character, in any way.
What a lot of crap.
I mean, the costume department is absolutely insane.
You have no chance.
Who is this? This is some of the worst styling I've ever seen on any show, let alone a show that I know and love so well.
Yes, I said it's enough. I don't care about her hair.
I feel like I'm witnessing a murder. What is this? Look at this. I hate this so much.
What a lot of crap.
I actually found some old photos of me in New York City doing exactly that. The fashion influenced everyone and everything.
Oh my God, did you hear Megan last night?
I wasn't actually drunk. I was just so excited that I ran into her at the bar at the W Hotel.
Well, you gotta get controversial.
I don't even remember his name.
Hello there.
The fact that everyone hates this show.
That's the name of the game. Oh my God, did you hear Megan last night?
It's going up.
Is he queer?
What? I told you you're going to love him. He's hilarious. He's so funny. I wish he would join this show every day. I haven't played that in a long time. Yeah, my dad calls me up and I just start videotaping our our FaceTime calls. Because, yeah, he's a legend. Because he always says hilarious things. And that day he wanted to tell me how everything I was doing was wrong. You got to get to your subject quicker. God, all you do is talk about your hair. All right, well, while that was playing, we had several... we had some cash apps come in. Let's see what we got here. What were we at? We were at 105. All right. Monica sent $10. Don't dox me like Legal Mindset did. I won't. First names only. Although I admit I have done that on accident, not on purpose. But thank you, Monica. Kimberly also sent $10. So what are we at? What did I say? We were at 105. Oh, God, you're going to make me do math. 125? Are we at 125? Because I just got 10 from Kimberly. Was there a message there? Kimberly, it doesn't look like Kim sent a message. Let me check. Oh, she did. Medium wage contribution for more laundry soap and on-stream laundry folding. Yeah, we definitely have to do more of that. The laundry is still not done. All right, what else do we have here? So I think we're at 125. Cynthia, oh, that was yesterday. All right, let me check Cash App. Oh, I better check Rumble. Did anybody over at Rumble crack the seal over there on rants? Yes. Deb sent 5. Thank you, Deb. It says, gonna need more zeros on that check, Megan's dad. So we're at 130. And I didn't check to see if there were super chats while I was gone either. Where are we at? Moving the goalpost. So we're at 135 now. Moving the goalpost. My dad does it all the time. Doesn't like when I predict the new post position. Dads, man, dads. All right, let's get back to it. Stephanie, does that mean he will not pay me the 200 if we don't hit 200 from super chats? Is that what you're saying? Is he taking it back if he's not going to give me the 150 either? Do I have to hit 200 or he doesn't match? Is that the deal? We got to get the terms down. I know, I'm so lucky to have my dad. I love him. All right, let's get this going. And my mom. My poor mom. She's been so sick.
Hospital records.
Was Maya
She's such a sweetie.
out of the wheelchair coming out of Tampa General Hospital?
No, she was not.
Was Maya Kowalski still complaining of severe pain?
Yes, she was, I'm sure.
Doesn't
Of course not.
CRPS, one of the problems with diagnosing and treating this disease is the variability of some of the symptoms?
I wouldn't consider that a problem. It's certainly a fact of the disease that different children have different magnitudes of symptoms.
At different times, correct?
It's not a smooth course to recovery. It's more of a sawtooth course to recovery. But
Right.
yes, the general trend is in one direction.
Good days and bad days.
I wouldn't quite put it that way, but I think I wouldn't quibble with you if that's how you want to describe it.
And are you aware that Maya Kowalski had a relapse in September of 2016?
We are, predicating this whole discussion, Mr. Anderson, on the assumption that this is CRPS, which was not the belief of the Tampa General Hospital staff or the Lori Children's Hospital staff. And so it wouldn't necessarily be expected that her course is going to follow the typical course of CRPS, and she didn't have CRPS.
Doctor, I just asked you whether or not she had a relapse in September of 2016.
I think you said a relapse in CRPS, and that's why
Yes.
I'm saying, well, I don't think she had CRPS, so she couldn't have had a relapse of CRPS.
Yeah,
But yes, she had a decrement, a decrease in her behavior, function. Yes.
And are you aware that through the entire course of the spring and summer of 2016, she was on that sawtooth path of getting better?
She would respond to ketamine, and then after, typically, her ketamine seemed to be at intervals of approximately once a month. And so she would feel better after the ketamine, and then she would begin to feel worse, and she would ask for another ketamine treatment, and she would feel better again. So yes, it was an undulating course. She felt better after many of the ketamine infusions. That effect wore off, and then she went back for more.
Well, this is a disease that you don't cure, you manage, correct?
Oh, not him.
What disease are we talking about?
Not him.
Complex regional pain.
He cured little girls. All the 10-year-olds who came to him, he cured. He's Jesus. After Jesus got out of the dumpster, apparently he opened a pain clinic in California, and he's curing little girls everywhere.
Again, I don't think she had complex regional pain syndrome. So if you want me to answer hypothetically about CRPS,
Hypothetically then, CRPS, you manage that, you don't cure it.
no, I would not put it in those terms.
Well, you think you can give somebody a shot and it'll go away?
No, of course not.
Or a pill?
Of course not.
So you think that just by continuous physical therapy, the rest of their lives, that's going to do it?
I haven't said that either.
Okay. So I understand that you say that you do not agree she had CRPS, but you've been through the records, have you not?
Yes, sir.
All right. And so you have seen then that, for instance, Dr. Chopra noticed or documented. Okay. First, I want to know now, you are refuting the diagnosis of CRPS by at least 5 physicians. Are you not?
I'm telling you that in my reading of the chart and in agreement with many physicians who saw her in children's hospitals, that I didn't see any evidence to support the diagnosis of CRPS.
Well, none of them after Dr. Kirkpatrick disagreed with the diagnosis. True?
After Dr. Kirkpatrick,
Once Dr.
All
Kirkpatrick,
Children's Hospital did not agree with the diagnosis.
well, are you aware that they billed for it the entire time?
It's a different matter. Once something gets in the medical record, it often stays there. And the billing people simply look at diagnoses that are written early on and carry through with them.
And all of the doctors and nurses and social workers through the entire 3-month stay, they just let it follow through, the diagnosis.
I don't know what you mean, really let it follow through.
All right. And so, for instance, Dr. Barr, a neurologist, diagnosed it independently as CRPS. True?
No, not true.
Dr. Spiegel diagnosed it. Are you disagreeing with whether he's a neurologist or not?
No, I'm telling you that he didn't diagnose CRPS.
Are you saying that Dr. Elliott did not say he refuted the diagnosis?
No, Dr. Elliott said it was not CRPS.
I could have
No,
sworn
he said he
did
couldn't rule it
believe
out.
CRPS yesterday.
I wasn't here yesterday. I
He
didn't
said he
hear
couldn't
say.
rule it out.
Dr.
In his
Spiegel.
deposition, he said it was not, and in his notes, he said,
Did Dr. Spiegel testify it was CRPS?
remind me who Dr. Spiegel is, please.
Did Dr. Hanna testify it was CRPS?
Yes, Dr. Hanna. I didn't hear his testimony in court, but
Dr.
in his deposition,
Kirkpatrick.
he did. Dr. Kirkpatrick called it CRPS.
Dr. Cantu.
Dr. Cantu.
And so you agree with the Budapest criteria, I gather?
Yes.
All right. And so in going through, you had to notice that, or see, I'm sure council provided you with photos showing dystonia of Maya.
Well, I think what we know in hindsight is that it wasn't dystonia. It would come and go at will. And there were lots of times when the dystonia was not there. And within the same day that it was there, or it seemed to be there. So it was something which was, it wasn't dystonia. It was, could have been conversion disorder. It could have been confabulation. But dystonia is something which is there all the time and then gradually gets better. If it does get better and then goes away, it doesn't come and go. The stiffness in the ankles doesn't come and go in the same day. And there were many descriptions at Tampa General, at Lori Children's Hospital, and at All Children's Hospital of her feet being in a normal posture under the covers or during the day, and then
They have no pictures,
not in a
though.
normal posture when she saw that she was not being observed.
Move to strike the doctor's testimony, the portion regarding psychological diagnosis. So now, is Maya's dystonia voluntary or involuntary?
Can't say.
You would agree it's involuntary.
No, I said I
she has no
can't say it
control.
was voluntary or involuntary. I don't have enough knowledge of her psychological state to make that observation.
When somebody is under general anesthesia, they lose the ability to control their arms and legs, do they not?
That's true.
Can we bring up 2529-61? Do you recognize that as dystonia?
No, I don't. It's not dystonia. If you look at any patient under general anesthesia, any patient, their feet do that when they're under anesthesia. Which is why under anesthesia and in an intensive care unit when children are unconscious, we're very careful to prop their feet up so they don't develop constrictures. So that would be the typical look of 2 feet under general anesthesia, sir.
All right. So the fact that they're pointing inward, you think has no significance?
That's right.
All right. Do you have any photographs of Maya Kowalski otherwise under general anesthesia where you can see that better?
None that I can think of.
Do you have any photographs around this time that demonstrate Maya Kowalski's feet staying perfectly straight?
During what time?
Leading up in the fall of 2015.
The fall of 2015? Hang on one second. There were, well, I mentioned the photograph from July the 30th, 2015, when she was being carried in a man's arms, and her feet did not look dystonic or like the photograph that you just showed me. That would be the only photograph that I remember seeing around the time.
I just want to get this straight then, doctor. Are you saying that a physician who diagnosed Maya with CRPS was deviating from the accepted standard of care?
No, not at all. I'm saying that he was wrong. I'm not saying it's not a violation of standard of care to be incorrect.
All right. So you also, well, let me ask you, between December of 2015 and September of 2016, do you have any photos indicating no dystonia?
Sorry, the dates again?
December of 2015 through September of 2016. That is leading up to, or even up to the day of going into Johns Hopkins.
There were 3 photos dated 8/16, 8/28, 8/31, 2016, in which her feet, at least in one of those photos, I can't remember which one, her feet were flat. The ankles were 90 degrees.
Okay. So now, is it your opinion then that after the OT, the PT, and the psychotherapy at Tampa General Hospital, then that she should have been cured, or whatever you're calling it, better?
No, 4 weeks in a hospital of that sort would not be sufficient not a sufficient amount of time. Wasn't the right, I mean, she was seeing a psychologist, but the problem was not yet identified, and the therapy the psychologist was using, if any, was not being directed specifically to what the problem was. So no, that was why Tampa General recommended that she transition to the outpatient pain setting, where the therapy could be more directed for what her problem was.
All right. And then the 13 weeks at Johns Hopkins then, were they doing things correctly?
Yes.
Okay. Well, under your program, I think you said that the type of psychotherapy they should receive is virtually daily, correct?
No, it's our program provides it weekly or biweekly, twice a week for patients who are doing okay, but if they're refractory and still struggling after several weeks of once or twice a week physical therapy, once or twice a week psychotherapy, we bring them into our program where they can have that daily.
Did you or did you not tell this jury just before lunch that under your program there was intensive psychotherapy virtually every day?
Oh, that was in our rehabilitation program. Yes, that's exactly right.
Do you know how many hours of psychotherapy, psychological therapy that Maya Kowalski received during her 3 months at
So
Johns
this
Hopkins?
should be good.
I don't know. I did not add it up. I'll look at the billing records.
Well, for it to have worked, for them to have done what they needed to do, about how many hours do you think?
Well, it depends on the diagnosis, doesn't it? So it's not CRPS, and it depends exactly on what's going on. And with psychological problems, of course, you can't give a pat answer. If somebody comes in with depression, anxiety, obsessive compulsive disorder, you can't say, well, I'll make you better in 10 weeks, and then you'll be done. It doesn't work that way.
Doctor, you're saying then that you can diagnose whether a patient has CRPS or not without ever seeing or talking to the patient. Is that right?
Well, I can read now upwards of 10,000 pages of medical records from 3 different institutions and draw a conclusion based on that and some photographs that she doesn't have CRPS. I can't, I can also, diagnose CRPS talking to someone on the telephone and having them do I can be highly suspicious, but I can't document CRPS without examining the patient, of course.
Well, in fact, you've stated previously that you can diagnose CRPS by telling somebody over the phone to just blow like they're blowing out a candle on the child's arm.
Well, I think diagnose was, I know I used that example in a video. It's probably an exaggeration, but there's very few things that will cause that kind of pain for a child. And again, that's in the background of a mother telling me.
Cynthia, thank you for the super chat, bringing us up to 140. We're getting there. We're getting close. Megan, you might want to go over this. Top all children's executives resign following Times report on heart surgeries from Tampa Bay Times. Holy cow. What? This is new? Tampa Bay top. Was it surgeons you said? No, administration. Hold on. I'm looking for this. All children's executives. Holy cow. All right, let's look at this. When was this? In 2018. Oh, I have to archive it because it's archived. So this is not recent. Okay, I understand. All right, I will look that over. Thank you.
It's one leg, getting a careful medical history, ruling out other things that can cause that, and then in that context, with that picture painted, if the pain is so intense that the breath of a parent or wind going over it or a sock being dragged over the skin causes that kind of intense pain, yes, I'm very, very suspicious of CRPS. And I would see the patient.
Well, one of the main reasons you thought that this may not be CRPS or was not CRPS was you thought it began in both legs, right?
It began in both legs and then rapidly became profound weakness affecting both arms, both legs, the trunk, and what was called whole body CRPS, which is, first of all, an entity that if it does exist, and it probably doesn't exist in children. If it does exist, it doesn't happen within the first few weeks of the problem occurring. There are so many factors, Mr. Anderson, that just don't add up to CRPS.
This child's CRPS began in her right ankle following a gymnastics event. You're aware of that?
Object Foundation, Your Honor. Overruled.
Her CRPS didn't develop in her right ankle, Mr. Anderson, because I don't think she had CRPS. And at that time, she was not seen by anybody for the diagnosis of CRPS in her right ankle. So she wasn't diagnosed with CRPS in her right ankle.
So nobody diagnosed her with CRPS until she went to an expert on CRPS.
Until she went to Dr. Kirkpatrick.
Right?
Oh my God, this guy is really, really unlikable. He's making my skin crawl.
All right. So let's just assume the jury believes that her legs turned in 5, 6, 7, 8 photographs was dystonia. And assume further that the jury has been shown lesions that look like CRPS lesions. And let's also...
Oh, I can't wait to hear what he has to say about this. But first, Mary, thank you for the Venmo. Send $5 on Venmo. There's no message, at least not the one that I can see. Thank you so much, Mary. That brings us up to 145. We're getting there, Dad. You're going to have to get out the checkbook.
Did it come to your attention that there are photographs of discoloration of her skin?
Objection on a compound. Overruled.
I haven't seen any photographs showing discoloration of her skin.
You never saw any photographs of Maya being held down and her clothes taken off to check for CRPS lesions and her knees and palms showing discoloration?
Objection, argumentative.
Did you see those?
Overruled.
I have not seen photographs of that sort.
Would that affect your opinion if there were photographs of color changes?
Yeah, well, it would depend on the color changes, the location.
Well, would it change your opinion if there were objective measurements of one leg to another and so much as 2 inches difference because of swelling?
2 inches difference? In her
Excuse me,
legs?
you're right, 1.5 inches difference.
I don't think that's possible.
Okay, but let's just say that there was testimony from a board certified physician that said that. Would that affect your opinion?
I would question that. 1.5 inches is 5 centimeters. It's beyond comprehension.
Okay.
I would have to know what part of the body we're talking about as well.
So
what part of the leg? Are we talking the thigh or the foreleg?
I think it was the thigh, but the jury will know. So if you've got a child that presents to you with extraordinary pain and with variable but still extreme pain upon even brushing her skin, with skin discoloration, with signs of allodynia, with swelling, and the pain begins in one ankle and spreads up from that one extremity and then to the other extremity, wouldn't you agree that CRPS is an appropriate diagnosis?
No, not quite. I would agree it's an appropriate possible diagnosis. There are other possible diagnoses that would need to be considered, and which is why the criteria state that if there's no other reason for these changes, then yes, you can diagnose CRPS.
Doesn't the Budapest criteria say that if you've got 5 of those, then you have a diagnosis of CRPS, assuming you don't rule out other things?
5, yes, if there's nothing else to be ruled out.
All right. And finally, as to the amount of ketamine, you're not a really big fan of using ketamine, are you?
No, that's not true.
Well, have you previously told audiences that cannabis, pot, would be better for children than ketamine?
No.
You did not say that during a 2018
oh boy.
meeting?
I think you're taking my comments out of context, completely out of context.
Can y'all come up, please?
Oh boy, I love Anderson on Cross. He knows his stuff. He's already researched you, sir. He probably has a videotape of you saying that you want to give marijuana to little children. Do you enjoy giving pot to little girls? I love him. I really do. I love him. Love, love, love. I like Jack's pink tie today. Jack always looks good. He's a sharp dressed man, I tell you. Not going to be single for long, probably. I hope. He needs a good woman. Those kids need somebody who can cook them some Polish food. All right, what did it get sustained? What happened?
Make it take the chair.
Is he going to change his line of
Have
questioning?
you seen any photographs of
Yeah.
Mike Kowalski's reaction to light touch?
He got sustained
Have
on
you seen
that
video of
one.
it?
No, I haven't.
2666. This is from October 4th, 2015.
That doesn't feel good when I touch your legs, right? But your tummy, when I touch your tummy, that feels good, right?
This poor kid.
Are those tremors?
No, I don't think so.
Is that aldynia?
It looks like it could be allodynia. It's pretty strange actually. It's strange in my eyes. It's kind of strange behavior and oftentimes lack of withdrawal and tremulousness, not tremors, but tremulousness in response to it. Yeah, it could be allodynia, but it could be other things as well.
And that was dystonia.
Oh God, he is really insufferable. How can he know? Lying by the sea. Thanks for the super chat. We're up to 150 now. $50 left to go before Dad sends me 200 on top. Thanks for the coverage and safe space to be inappropriate. You're welcome. This is what we're here for. This is a safe place. It's a safe space for all your inappropriate comments. Don't worry, I will never shame you for being inappropriate in the comments section. Who the hell has the time for that anyway?
It too, wasn't it?
No, it wasn't.
Your witness.
Mr. Hunter?
Bert, could be bed bugs. Yeah, it could be anything, I guess. Those are not tremors. Maybe bed bugs. I don't know. No.
Just ask you a few questions.
My dad wants to know if you only have poor people as fans. Yes. These are the pores. It's okay. We're all pores here. Dad, don't pour shame the fans. Don't. Do not pour shame everyone. Yes, we're poor. We're all poor. How can we not be poor in this economy? Bread is like $18. Gas is like $150. We're all poor. We're being dad shamed. My dad always wants to know why you haven't built your own business from the ground up by now. Like, you've been alive for 30 years. When I was 30, I had a restaurant and a grocery store and an entire building. Yeah, Stephanie. No doubt. Stephanie says she bought one stupid sandwich yesterday. It was $18. It's ridiculous. We're all poors. Eric says we're medium poors. AP, medium poor. Says the guy who hasn't dropped a super chat. Y'all poor. All right, I will go back so you guys can hear what Anderson asked.
Frank?
Wait, I guess I didn't go back far enough.
It wasn't.
No, it wasn't. And there's sometimes lack of withdrawal, and in my eyes, it's kind of strange behavior, and oftentimes lack of withdrawal, and tremors, tremulousness, not tremors, but tremulousness in response to it. Yeah, it could be allodynia, but it could be other things as well.
And that was dystonia too, wasn't it?
No, it wasn't.
Your witness.
Oh, he said it wasn't dystonia. I can't wait for the jury to get in on this guy. The jury's going to eat him for lunch. Oh, the chat is poor but rich with love. That is true. I love you guys. Oh, Rumble sent a Rumble rant. Let's see. JoJo Perks sent $10. How much to get him to come on and talk hair with us?
Council showed you a
I'll ask
calendar chart of various infusions by Dr. Hannah.
Yes.
That chart does not show the dosages.
Yes.
And the chart does also does not show, excuse me, I'm sorry, the various
Wait a minute.
medications that were being
Wait
given
a
at the time,
minute.
correct?
Is he moving the goalposts? Stephanie, wait. He says if these cheapies will get the chats up to 250, he will match it. Hold on. He said 200. We're already at 155. 155 now. We're almost there. He better not be changing it. He's sending the check. Even if we don't hit 200. Oh, he's just saying he's moving it up. So he's willing to pay 250. So he's still going to give me whatever I raise, right? But okay, I'm just checking. He says if you want more money, get more chats. Oh, Lord. Oh, I can't wait for jury questions. This is going to be great.
Do those make a difference?
Does what make a
Medications that were
difference?
being, excuse me, I'm sorry, the various other medications that were being given at the time, correct?
Correct.
Do those make a difference?
The dosages, for sure, yeah. Mhm.
What about the other medications that were being used by Dr. Hannah,
It would be good to have that background information.
such as Versed?
Yes.
We see that there was some diminution in the frequency of infusions in April and May, but then it began to pick back up in June and July, and then once again in September and October.
Yes.
Is that consistent with a lasting or sustained benefit from ketamine?
Our experience and the literature shows that in the case of CRPS and other.
Just talk about your experience, though.
All right. In my experience, low-dose ketamine infusions in patients with CRPS lasts, let's say 3 to 6 months.
Dad, I need you to answer this question. Tell Stephanie to type it in the chat. Give me your opinion of this witness. I want to know. I want to know what your opinion is of him, of his testimony, and especially that tie. I want to know what you think, Dad. So, Stephanie, you have a Boosh. Apparently, you have been invited into the family since you have that insight. You said that my dad, he's got game. He's a grifter. It's true. It's true. He's the ultimate grifter. He's very good at it. He's a hardworking man, but he knows how to wheel and deal. This one. All right, Dad. I want to know what you think of this witness. I want to know what you think of his tie. Dad says he's an asshole. This is so typical. Everybody's an asshole. I thought you'd come up with something like more creative than that. We do need the tie opinion though. What do you think about his tie? Other than he's an asshole.
3 months on the short end.
And is there a difference between single-day infusions and multi-day infusions in your experience?
We typically just do multi-day infusions.
And are these, is the need for the apparent need for these infusions consistent with any degree of recognizable success of the therapy?
Well, first, the magnitude, the size of these infusions is enormous. 1,000 milligrams, 1,300 milligrams in 4 hours. It's really unbelievable.
Catherine, that's exactly something like he would say. It's queer. Nick says the sad thing is that tie probably costs more than my computer. Probably. He's definitely not one of the poors, this doctor. He is not one of us.
And you say they're not successful because the duration of effect is so short. And one would expect her to feel better for a few days, for sure, because she's still got ketamine in her system. And that causes a euphoric state, which is why it's an abused drug on the street.
Counsel asked you, well, let me back up just a moment. Is dystonia something that can wax and wane?
No, it can't.
Does it become fixed?
We hope it doesn't become fixed. It's a neuromuscular phenomenon. So the muscles are contracting, causing the joint to take that configuration. It can be any joint in the body. If it's not dealt with, then the tendons constrict, the muscles constrict, become permanently fibrotic, and then it becomes permanent. Then the only fix is surgical. But dealt with, it's not permanent. But it doesn't come and go. True dystonia does not come and go.
Is the use of intrathecal pain pumps an accepted therapy for CRPS?
No, not at all. Never. Never. It's never acceptable therapy.
Okay. Why is that?
So apparently my dad has made the comment that Stephanie will not type. She's censoring it. That the tie makes him believe that he may be a queer, but he's not sure. He's not sure. But the chat is pretty sure. The chat is pretty sure that the I don't know. I just think that the chat's pretty sure. If I was on the jury, says Flux, is being an ass a requirement to being a doctor? That would be a great comment. That would be a great question because, man, there have been some seriously unlikable doctors in this trial. Stephanie says this dude is almost as unlikable as that bizarre expert in the Johnny Depp trial. Dr. Spiegel? Yes, with the lip smacking and the weird lip movements. I remember him. Fox Daddy has the same opinions as the chat. It's true.
It's way too invasive and way too dangerous. The risks are too high.
Counsel asked you whether it was a violation of the standard of care to be incorrect. I believe your answer was no. Okay. Is it a violation of the standard of care to offer the wrong treatment?
If it's done in good faith, it depends on the treatment. It depends on the treatment. If you thought somebody had pneumonia and you were wrong and you gave them an antibiotic in the correct dose and the correct time, no, that would not be a violation of the standard of care. That would be being wrong. If you thought or called a patient as having CRPS and gave them 1,000 milligrams of ketamine or 1,300 milligrams of ketamine in 4 hours, yeah, that would be that is the delivery of the ketamine that's a violation of the standard of care, not being wrong about the diagnosis.
Thank you.
And anything else, Mr. Anderson?
No.
Wait, see how many questions are coming.
Oh, yeah.
Jury questions are coming.
Well, there's more coming.
All right. They have to fight about it for a while. Oh, shoot. I just made a big mess. All right. They have to fight about it. Let's get to the jury question. Holy cow. How many jury questions are there? How many pages? It looks like a lot.
You seated members of the jury. Investigation, you received no information. Is that all correct? You have not been approached by anyone about this case. Is that correct? And you have seen lots of media accounts about this project. Okay. I will tell you, we are able to ask most, but not all of the questions. But
18 pages
the vast majority of the questions we are
questions.
going to be able to ask. And,
Wow.
Doctor, you understand you're still under oath?
Yes, sir.
Let's start. Let's start right the time down. Doctor, how is Maya doing after her discharge from Johns Hopkins All Children's Hospital?
The latest information I have is that she's doing very, very well. Looking at her physical therapy notes after discharge from January, I think the last note I looked at was in July. She's gone in January from being wheelchair bound, unable to bear weight, all of her weight on her feet, having to stand with support, get out of a wheelchair and transfer to a bed or a toilet with support and help. That was how she was in January. She underwent physical therapy roughly twice a week, going forward from there. And by July, she's described as walking around, no pain complaints. There was a quotation from her father in I think in the summertime, just describing how well she was doing. And I understand that today she's a high school student. She's doing well. She's in some kind of.
Her family is probably terrified to say she's in pain anymore, because the second he says anything about it, they're going to say that it's not, she's faking it, and take her away from him again. Enchiladas Unbreaded, thanks for the $20 super chat. Popo, get your wallet out. Popo, get your wallet out. What are we at now? Let's see. We were at 155. What did I say? 155. So we're at 175. Oh my goodness. We're only 25 away, and Popo has to write that check. You better not back out. Seriously.
Athletics. So as far as I know, she's doing quite well.
What are withdrawal symptoms of someone that is physically dependent on ketamine?
Well, I've never seen or heard of anybody in my life getting doses of ketamine like this. 1,000, 1,200, 1,300 milligrams in just a few hours. So I can't say that I have any experience with that, but I have seen ketamine withdrawal. Back in the old days, when we had kids undergoing radiation therapy at Boston Children's, they would come in every day, Monday through Friday, for 6 weeks for radiation therapy, and we would have to put them to sleep because you don't want them to move at all when there's a radiation beam going into their body. You want to kill the bad stuff, the cancer, and not the good stuff. So we used to use ketamine. We have better drugs now, but we used to use ketamine. And as we saw with Maya, the dose would need to be increased from week to week to week because they develop tolerance. That means you need more of the same drug in higher doses to get the same effect. That's tolerance. The other side of that coin is when somebody develops tolerance, they become increasingly physically dependent on it. So if you have any drug, that's what happens. And the symptoms of withdrawal are going to be the opposite of the symptoms that you're trying to get by using the drug. So think about narcotics. Narcotics make pain go away. Narcotics cause constipation. Narcotics cause drowsiness. The opposite of those three things that happen with withdrawal. They feel pain all over their body. Their bones feel like they're breaking. They have wicked diarrhea. And they're wired, absolutely wired. They're not sedated. They're the opposite wired. The same thing's true with every drug, you name it, every single drug. And in fact, in Maya's case, she was treated with steroids for her asthma in high doses. And when those were stopped, she had none of her own steroids in her body and had symptoms that could be attributed to having inadequate steroids and being at risk for infection and things of that sort. So with ketamine, when we used to give ketamine, we would see kids sometimes come in on Monday begging for ketamine. They had it Monday through Friday. They go home for the weekend. They're not getting radiation therapy. They come in at 8 o'clock in the morning for the radiation therapy. They can't wait to get their next dose of ketamine. They're anxious, sometimes begging for the ketamine. They feel pain because it's all the opposite of what ketamine does. So there's no question that ketamine, call it, is addictive, is habit forming, but physical dependence does occur with ketamine. And those would be the symptoms that I would predict. Fortunately, I've seen it rarely, and I've never.
He's the only person to have testified that there's a physical addiction to ketamine. Everybody else said there isn't, and that it could only be psychological. Amy, thanks for the Cash App. $15 for Pay Up Daddy. What are we at? We're at what's 75 plus 15? Not 190. We're $10 away. $10 away. Oh, I better check Rumble. Nope, Rumble's still
I've seen a kid
very poor.
withdraw after such high doses because I've never heard of such high doses being given before.
Is it possible that the quote symptoms, end quote, Maya would present as quote CRPS, end quote, be withdrawal
Melanie, $5. We're what are we? 195. We're $5 away.
symptoms?
It's a great question.
What was the question? Let's
Is
hear
it
it again.
possible that the quote symptoms, end quote, Maya would present as quote CRPS, end quote, be withdrawal symptoms?
It's a great question. That was one of my hypotheses, especially when she was in the ICU at All Children's Hospital. She was showing, she was agitated, she was screaming for ketamine. Those could have been withdrawal symptoms that she was having. And so that's possible. That's definitely possible.
What is the half-life of ketamine?
Off the top of my head, I'd have to look it up. I would hazard to guess it's in the range of, sort of like in the range of what morphine is, which would be 2 or 3 hours.
We have heard testimony that not all physicians that assess Maya, they did not always assess temperature changes or no color changes or assess her skin or other things, the Budapest criteria, or the other things on the Budapest criteria. Can you make a certain determination that it is not CRPS since you did not assess Maya during this time yourself?
Dr. Kirk.
Scrody put us over the top. Popo, you're going to have to write that check. We hit $200. Woohoo! Good job.
Patrick.
Maya, determination that it is not CRPS since you did not assess Maya during this time yourself.
Dr. Kirkpatrick and Dr. Hannah described her limbs as being cool. I don't know what that means. When I have a trial with CRPS, one limb is colder than the other, and we use 2 degrees as the threshold. It's rather arbitrary of whether that's significant or not. Now, how do we assess that? It hurts too much to touch their leg with the back of your hand to see if it feels warm or cold. And Maya certainly wouldn't have let somebody do that by description. So what I use is one of those thermometers where, well, they're very common. They didn't used to be common, but you see during the COVID pandemic, you saw people shooting those at your forehead and measuring your temperature. A little laser beam comes out, which shows you where you're aiming at, and it uses infrared to tell you the temperature.
Yeah, Josephine, this is a really good point. He just said he has kids coming in begging for ketamine. So it's not just Maya. How many kids have they addicted to ketamine exactly? And I don't think I buy this whole story because we've been told by multiple other professionals that ketamine is not addictive, including the pain specialist at Johns Hopkins, Dr. Elliott, or as we know him, Dime Store Pee Wee Herman. He said it was not addicting, other than psychologically addicting possibly, but there are no physical addictions.
So we use one of those. We buy them on Amazon for about $15, so we don't have to pay a medical supply company $100 for them, but they're the same device. So, and they measure temperature very accurately up to 1/10 of a degree. And so we have a chart. We shoot the big toe, top of the foot, the ankle, the shin, the back of the calf, the thigh, and we just record those measurements and compare left and right and look for a difference. And as far as color change goes, that's obvious.
Stephanie, tell him he better scribble out the entire amount. You went to Rumble and couldn't figure it out. You have to make an account. If you don't have an account, you can't do it. So just make an account. He's going to have to write a check, but he wants to know if he can make payments. Tell him to use mom's phone and PayPal me right now. The entire amount. I'm not accepting payments. There will be no payment plan. Especially because he's not a poor, and I know that. So no payments for you.
As I said, I provided some photographs to Mr. Hunter. He asked me for some photographs of what CRPS looked like in my patients. Some of them are really horrendous. You have one leg that's pink, one leg that's deep blue. So that's pretty clear. I didn't get that. I don't know how Dr. Kirkpatrick and Dr. Hannah assessed temperature or anybody else subsequent to that, but I suspect that really wasn't done.
Doctor, you stated many times that Maya does not have CRPS. but also stated you never examined her. How can you come to this conclusion?
I can come to that, well, because I've seen 1,000 or 2,000 cases of CRPS, and it's sort of like looking at that scratch on her forehead. You look at that and say, "What's a scratch? It's probably a fingernail scratch." You just know it when you see it. When you don't see what you're expecting to see with CRPS, it's not CRPS. I mean, if you told me somebody was an amputee and I looked at a picture of them and they had all four of their arms and legs, I would say, no, they're not an amputee. It's as obvious as that. It didn't look like CRPS. It didn't sound like CRPS by description. There were some emails that her mother wrote to herself, but in Maya's voice, similar to the blog that she was putting out. I don't know if that's something you were shown, but in Maya's voice, she's saying she's the youngest patient ever in the world to have total body CRPS. Then she said she's the youngest kid in the world to ever get ketamine coma. Well, I don't think she had CRPS. I don't think she had whole body CRPS. What are the odds that this child was the first kid in the world to ever have this? That's how I would say she didn't have CRPS. I don't think the odds are very large that she was the first kid in the world to ever have a condition that nobody else had ever seen before.
Is there any medical oversight on the dosing of ketamine?
I'm not sure what's meant by medical oversight, except this, that, for example, our hospital specifies an acceptable dosage range for using ketamine outside of an intensive care unit. You want to use more, you have to be in the intensive care unit, which is impossible. Why is it impossible? For the reason of ketamine, because insurance won't authorize it. The ICU is super busy and there's just not a bed for something like that. So I'm on a email list server of pediatric pain. People, I don't know, thousands of people from all over the world are on that list server. And the question comes up from time to time. Somebody says, hey, we want to start using IV ketamine infusions in our hospital. And they ask for advice. And different physicians write in and give the guidelines that are in their hospital. I would say at Stanford, for sure, we have the most liberal guidelines of any children's hospital I know of. And we only allow it to go up to 1 milligram per kilogram per hour. And as I said earlier, in 20 years, we've only had one kid who needed to go that high. And she was a redhead, and redheads are notorious for needing higher levels of anesthetics than people who don't have red hair. And there's a chemical reason for that. So that's the medical oversight, is there are policies and procedures that hospitals have that say this is what you can do, and outside these guardrails, you can't do it. Now, who enforces that? If I were to write an order for 5 milligrams per kilogram per hour of ketamine in the hospital, the nurse would say, no, I'm not going to do that. And I might get into an argument with her or him, and they would pull out the policy off the web and say, it says right here, you can't go there. And that's it. I would be in serious trouble if I really did that.
Is it common for a diagnosis of CRPS to be questioned by physicians?
I think there was a question Mr. Anderson asked, I think Dr. Elliott, about honoring a diagnosis that comes in the hospital. So how could you not honor Dr. Hanna's or Dr. Kirkpatrick's diagnosis? And to that, I would say, we don't honor diagnoses. We honor patients, we honor parents, we honor people, but a diagnosis is an idea, and they're wrong sometimes. You wouldn't want a doctor who accepts you from another doctor outside the hospital and just automatically agrees that this is the diagnosis, these are the drugs you should give. It's going to be your reputation on the line if that's wrong, because you're the one giving the drugs. So you're going to ask the question, is this right? And sometimes it's just really obvious. You have, like in Maya's case, comes into the hospital with a diagnosis of CRPS, pain specialist is called and says, this doesn't look like CRPS. It just doesn't. And so then you have to take a step back and say, well, it doesn't look like CRPS. What else could account for what we're seeing? And that would be true for any disease. If somebody comes in with a cough and the doc on the outside says, I'm sending this guy in for pneumonia, I want you to treat him with antibiotics. And you put a stethoscope on his chest and say, he doesn't have pneumonia. You do a chest x-ray, he doesn't have pneumonia. You treat him for something else, what he does have.
Next question. Does the diagnosis of CRPS automatically raise questions of psychiatric issues?
No, never.
Next question. Do you require IQ tests to treat CRPS or for entry to your pain clinic?
Oh, no. Why would we do that?
What role would IQ play in pain treatment, assessing meds or source?
It would not figure it out. We treat children who are cognitively impaired. We treat children who are near genius and everything in between. And, we would treat them no differently, except that when you're treating a cognitively impaired patient, it's challenging to figure out what's going on because they can't really describe it, or an infant for that matter. But no, we don't do IQ testing. We don't treat anybody differently, whether they're smart or stupid.
If in a quote breakthrough case, end quote, it was whole body CRPS, would someone experience pain from a charm bracelet, anklet, pulling hair back tight, or application of mascara and makeup?
Yes, they would. Our children and women, adult women with CRPS don't shave their leg with CRPS because it hurts so much to drag a razor over it. It hurts to drag a sock over it. They can't wear jeans. Our patients with CRPS, and probably all patients with CRPS in Florida, if it's in their legs, wear shorts 365 days a year because it's too painful to put pants on. Fortunately, I live in a place where that's okay most of the year. They live in Boston. I think they're out of luck. But that's how painful it is. Yeah, it would hurt.
Has any pediatric CRPS case?
All right, hold on. Somebody on that jury, that one with the ankle bracelet, is I think believing the defense, because that was definitely a pro-defense question. Because remember when we were wondering, why did they focus in on her ankles in that picture? Did you notice that she was wearing an ankle bracelet? So is the defense, is the jury, is that juror now saying, well, she was wearing an ankle bracelet, so she couldn't have been in that kind of pain? I think that's what that was about. One of the other jury questions that I thought was interesting was before that asked about the IQ test. Somebody figured out she didn't need that IQ test for what it is he's saying, you would treat her for. So why the hell are they doing that? Cheesy, the chats disappear because YouTube has a silly filter that we can't turn off. And so that's why the mods are there. The mods are there to unhide your comments that YouTube hides, because YouTube thinks words are violence.
Reoccurred in your center?
Yes, it has.
At what age?
It's never reoccurred so far, knock on wood, in children who started at Maya's age, 10 or 11. As I said, those are our favorite to take care of because they get better the fastest, and they're usually cute little girls, and you feel really good about restoring them back to 100%. The teenagers tend to recur with greater frequency, and we published a paper on CRPS recurrences by sending surveys out to every patient we treated since 1984.
Woohoo! I got the PayPal from Popo. He sent it, and then he says, Dad says he and Mom won't have anything to eat now until next Saturday. Your attempts at guilting me will not work. It will not work. I know you are lying. I know that that's not true. You guys probably have a refrigerator full of too much stuff you got at Costco or wherever. Stephanie will make sure they have something to eat. Right?
And 1994, which is when I went to Stanford. And we sent it out. We got about a 35% response rate, which is pretty good for a survey, especially because we were using addresses and email addresses that were 20 years old. So we didn't know. A lot of the surveys came back as undeliverable. And what we found, we were kind of surprised that that ongoing pain was much more common than we thought it was going to be. About a third of the patients said they had no recurrence at all, no pain. And the rest of the patients had some kind of pain. Fortunately, most of them were mild. There's a young woman who's now a medical student at Stanford that we took care of a long time ago, 15 years ago.
Oh, so wait. So the jury call him out on the we've healed every 10-year-old who came to us, and they've had no thank you, Stephanie, for confirming they have 2 refrigerators and they are both full to the brim. I knew they would be. Their refrigerators are always jam-packed. Yeah, that's 2 refrigerators, folks. They have 2 refrigerators. Okay, so this guy, I got to go back on this because I want to hear the jury question. I didn't hear the jury question.
Much more common than we thought. We were kind of 20 years old, so which is pretty good for and survey on.
How long is this answer?
It's occurred.
It is. Yeah, it would hurt.
Has any pediatric CRPS case reoccurred in your center?
Yes, it has.
At what age?
Oh, well, then how come he said that he's had no reoccurrences? He said that he had no reoccurrences of CRPS.
It's never reoccurred so far, knock on wood, in children who started at Maya's age, 10 or 11. As I said, those are our favorite to take care of because they get better the fastest, and they're usually.
Yeah, he said, I'll give him the benefit of that. He did say kids he treated at Maya's age.
Cute little girls, and we feel really good about restoring them back to 100%.
Did
They're
he
the
just say
fastest,
cute
and
little
they're
girls?
usually cute little girls, and we feel really good about restoring.
All right, that was creepy. Can we hear that again?
Knock on wood. In children who started at Maya's age, 10 or 11, as I said, those are our favorite to take care of because they get better the fastest, and they're usually cute little girls, and we feel really good about restoring them back to 100%.
Is it me, or is that a really strange way to say that? I didn't understand that. I'm not suggesting there's anything wrong with him. I'm just saying it's a really strange way to say that they're our favorite patients because they're cute little girls. That's bizarre.
The teenagers tend to recur with greater frequency, and we published a paper on CRPS recurrences by sending surveys out to every patient we treated since 1984 and 1994, which is when I went to Stanford. And we sent it out. We got about a 35% response rate, which is pretty good for a survey, especially because we were using addresses and email addresses that were 20 years old, so we didn't know. A lot of the surveys came back as undeliverable. And what we found, we were kind of surprised that that ongoing pain was much more common than we thought it was going to be. About a third of the patients said they had no recurrence at all, no pain. And the rest of the patients had some kind of pain. Fortunately, most of them were mild. There's a young woman who's now a medical student at Stanford that we took care of a long time ago, 15 years ago. And she's an avid hiker, and she tells me when she goes on a really long hike, her foot hurts afterwards.
Does she step in any snake holes? Does she go hiking with Bob by any chance? If I'm on the jury, I'm going to be like, does your patient hike with Bob? And if not, she should maybe start so she could keep him away from the snake holes that he keeps stepping in.
Probably the CRPS, but so the pain can be persistent or recurrent, but it's usually not disabling. And then we have had children whose CRPS has roared back at 100%. They come back, they look sometimes even worse than they did in the first place. It could be a year, 2, 3, 4 years later. Then we do the same thing that we always do, and we make it go away again.
What was the length between occurrences of symptoms?
The length between
the occurrence of symptoms, and it goes back to the question about reoccurrence in your center.
I'm not sure I quite understand the question.
Pro tip, don't hike with Bob.
Are you asking about the evolution of the development of CRPS after an inciting injury? It's usually days, maybe a week, 2 weeks at the most. But usually the change morphs from normal pain, if you want to call it that, to this really excruciating pain. We've had kids, a typical scenario, this is really typical scenario, is a child injures their ankle or foot in a sport, and they go to the emergency room, photograph, x-rays taken. And
that's what Maya did. She injured her ankle when all this started, which you said you didn't believe.
The doctor's probably not used to looking at pediatric x-rays. They look different than adult x-rays, and they can look a little funny sometimes. It says, well, I'm not sure if there's a fracture, so let's put you in plaster just to be safe. And they put them in plaster, and about 5 days later, they're in excruciating pain and cut the cast off, and they have CRPS. Because immobilization is I think one of the triggers of CRPS.
Snivels or Snivels, I never know how to say that, says almost like your treatment isn't actually curing, it's just riding it out till it subsides. That is what it sounds like, isn't it? Because we have heard that that CRPS comes and goes. So is he really doing the curing, or is this just the natural progression of the pain? I think it's a good question.
When you immobilize a limb. In fact, there was a study done by a colleague of mine named Stephen Butler in Sweden.
Sir, let me just, the question had to do was between the length, so.
Did I answer the question? Typically, a few days to 2 weeks between an inciting event, if there is one, and the development of CRPS. In terms of recurrences, they can occur almost any time, but what I've seen is, I would say, 6 months to a couple of years for a recurrence.
Was it ever, or when has 25 milligrams per kilogram per hour been within the reasonable standard of care or used in practical application?
Never, not even for general anesthetic. Never. I've never heard of doses of that sort, that magnitude.
In CRPS, final requirement to rule out other diagnoses versus psychiatric requirement to find the same before diagnosis. Are these directives in conflict here?
they were in conflict with what Dr. Kirkpatrick.
Oh no, why says it sounds like witchcraft. Actually, I'd probably trust witchcraft more. You joke, but these days I think I would rather go to like a Native American reservation and go to the medicine doctor and go to the medicine woman before I would go to a hospital for pretty much anything except for my, broken bones. Havy says, Megan, can you drink with your parents watching? Well, I'm 47, so I think it's okay by now. I think I just haven't started the day drinking yet. I'm not through with my tea. I have this really good Bengal spice tea in my stainless steel mug, and it's still nice and hot with honey and cream. So I'm still working on that.
They didn't, neither of them read the notes from any of the hospitals where she had previously been taken care of. And I think if they had read those notes, they would have stopped and questioned the diagnosis. I hope they would have stopped and questioned the diagnosis, because I think those notes are very telling. They're that the symptoms that Maya was exhibiting came and went.
All right, the chat is demanding day drinking. That's fine, because you guys just want permission to drink, don't you? Fine. I'll put a little bell mead in my tea. It'll make a little hot toddy. Not too much though, because I'm almost out of tea. All right, a little whiskey in the tea. We're good. All right.
And her
now
reports of symptoms.
May
and
the
what
day drinking
the medical
commence.
professionals observed, and by medical professionals, I'm talking about doctors, therapists, nurses.
Huzzah!
What they observed and wrote in the chart were very, very different, oftentimes, almost every day, than what was being reported to them by Maya or her mother. So that kind of discrepancy to me raises red flags. If a child can go from, let's say, feeding herself with both hands, brushing her hair, smiling, to screaming in pain, and when a nurse comes in to give her a pill, say she can't lift her arms off the bed to put the pill in her mouth, there's something wrong there. And it raises red
Again,
flags.
do you have video, or do you have videos of this happening? Because so far, all we've heard is you guys saying that these things happened, but no one has actually shown us evidence of it. Start day drinking with Popo, says Flux. I don't know if Popo's is Popo day drinking, Steph? You should make him a little drink. Make him a little drinky drink. He likes a Manhattan now and then, although you probably don't know how to make that. I could make you a Manhattan if I was there, Dad. Sorry.
Exactly what it was. There's a few possibilities, but that isn't how CRPS works. And that should raise questions about the diagnosis.
Testimony has described Maya's Johns Hopkins All Children's Hospital visit as an, quote,
is anybody,
interruption, end quote, in treatment.
Hold on. Is anybody besides Boosh McFadden going to do some day special K injecting? Some day ketamine? Yes. That's a joke. That was a joke. Put down the needles.
What was the presumed conclusion of the dosage for ketamine?
The presumed conclusion for the dosage of ketamine that she was getting from Hannah was it was too high by tenfold. The dose that they started in the intensive care unit was 3 milligrams per kilogram per hour. And that wasn't adequate to stop her from screaming in pain and thrashing. It was raised to 5 milligrams per kilogram per hour, and nobody felt comfortable going above that. So nobody had ever experienced giving doses higher than that in or out of an operating room. So that's where they leveled that off. Now, if you look at whether the ACH admission was an interruption in her therapy, I would say it was, and that's a good thing. Because if you look at the overall trajectory, from when she was admitted to, let's say, the next summer, she was better the number of drugs that she was on, starting with a huge list of drugs, and slowly narrowed down to virtually no pain medication at all by the next summer. She's on a little asthma medication, a little allergy medication, but nothing directly for the CRPS. And yet, in spite of that, she's doing great in the summertime. And why was she doing great? I think because she wasn't going through periodic ketamine withdrawal, and she was getting physical therapy at Agility twice a week.
It sounds to me that the jury believes him too. I think this might be the first witness that they have believed. So I don't know, but it sounds to me like they believe they find him credible.
Almost twice a week, almost every week for that entire period of time, and was showing continuous improvement. A few other things could account for that improvement as well. She's growing up a little bit, etc. But the point is that what they did was they put a stop to what was being done by Hannah, and that was a good thing.
Now, Doctor, we're about halfway through the questions, so let's see
Okay,
if we
I'll
can
try to
just answer the specific question asked. There's going to be opportunities for others to ask follow-ups. So let's just
So
try to
wrap
answer
it
both.
up. In
The
other
next
words,
question, can the CRPS pain starting in a limb radiate to other areas as well?
Yes, it spreads up to the body, can go all the way up to the thigh, even the lower back, and it can cross over to the other side in some patients.
Are most medical treatments for CRPS temporary, although effective for at least some relief?
Some patients are lucky enough to never experience CRPS again. And most patients, over 50%, that is to say, children over 50% will have some recurrences later in their adult life.
You stated CRPS does not usually reoccur when adolescent girls present with it and are treated. Is it not CPRS a lifelong condition, although fluctuating in severity over time?
No, if I said teenage girls don't, it doesn't recur in teenage girls, I misspoke. As I said, it typically doesn't recur in 9, 10, 11-year-olds.
well, how long
CRPS
have you
doesn't even
watched
start
them?
much before that age.
How long have you watched them? How old are they now? How do you know it's not coming back?
For some reason we don't quite understand, it begins to start as puberty starts to develop. Those kids don't seem to recur. I've never seen one in 30 years. The older teenagers will have some recurrence, but as I said, it's about 2 out of 3 will have some kind of recurrence, but it's usually mild. I've had my patients have childbirth after CRPS in their 20s or 30s and haven't had any kind of recurrence, even with that sort of a significant event. But in about a third of patients, it doesn't recur. So is it lifelong in them, or are they cured? It's hard to say. I mean, maybe 5 years later, they will have recurrence. I don't know. But almost all those patients who have CRPS in childhood and adolescence go on to live normal lives.
Next question. You testified Maya was in athletics. Can you tell us what she was involved in?
Maybe I have it in her notes.
Boosh.
I may,
Not only did the kids get away from him ASAP, they never called back. He doesn't know what happened to them. He said, well, they never came back. Well, maybe they went somewhere else. I don't know. I don't know. I don't think any of this, to me, if I'm a juror, none of this matters to me, whether she had CRPS or not, whether the diagnosis that Kirkpatrick and Hannah gave her was right or wrong. To me, it doesn't matter. I think her parents were doing the best they could with the information they had. They weren't getting any relief from the other places that they had taken her to, including Tampa General and Johns Hopkins. And they had a right to seek alternative therapy. And I want to know why it's okay if doctors kill you, but it's not okay if parents take you to do the wrong thing medically. It's okay if you get checked into a hospital and they overdose you, but it's not okay if your parents go try some alternative therapy and that doesn't work. But it didn't hurt her. You heard them testify she had no harm from the ketamine. None. So what case are they making? They're making that she may have overdosed at some point in the future if her mother was allowed to be in her life. And they actually are saying they think that she'd be dead now. Give me a break. Yeah, it doesn't mean they didn't abuse her at the hospital. No, none of that means it doesn't mean anything. If she has CRPS or not, if she has conversion disorder or not, the way Johns Hopkins All Children's Hospital treated her was absolutely horrific and abusive. Period.
let's see if I did that.
Shuffle, shuffle, doctor. Let's go. We don't have time for
Remember if
this.
it's my recollections, it's something like that, but I can't specifically remember without going back into the chart.
You don't
Next
remember.
question.
Okay.
You agree with All Children's Hospital's treatment of ketamine 5 milligrams per kilogram per hour in anesthesia dose. Per your testimony, Presidex, a sedative, and Haldol 1 milligram IV. With your experience as an anesthesiologist, do you think Maya would have been sedated, or do you think these medications could cause a mind-altering state in her and cause her to yell out at staff or cause her personality to be different?
The Presidex at 0.7 milligrams per kilogram per hour is a highish dose. 0.5 is typical. So it's not an extraordinarily high dose, but it's a pretty high dose, and it's enough to deeply or significantly sedate most kids. They'll be arousable, they can wake up and answer questions and move in bed, and then they'll go back to sleep. So she was on that, and she was on ketamine at 5, and it would be really unusual to be on those 2 drugs and be awake and screaming. And that was probably the reason, I'm presuming, for the Haldol, is because she was a wild woman and they needed to control her. Can't have somebody thrashing in bed, pulling out their IVs and things like that. Not to mention disrupting the entire environment by screaming. So Haldol is a major sedative that's used to calm people down. Now, would she be in an altered state? I don't think so.
You said that an intrathecal pump is way too dangerous procedure. Who is it that should make that determination, you or the patient?
I'm not the patient, for sure. I mean, you don't
Never
allow
the
a patient to
patient.
say, I think you need to take out my appendix.
Patients never know
I
what
need
they
a lobe of the
want
lung
or
removed
what they
something
need.
like that. I mean, they have no idea what the risks of an intrathecal pump are, which includes spinal meningitis.
Oh yeah, you have
They
no
don't work
idea.
that long. They
Did
tend
you
to
hear
clog
this
up
guy?
and et cetera. So
Patients have no idea about anything. You're just a bunch of stupid assholes. You can't make your own decisions about things. Who the hell do you think you are? What you think you have autonomy over your body and over your choices and over your no, you don't. Doctors they're the only ones with the right to tell you what to do with your body. They're the only ones. They're the smart people in the room. Who the hell do you think you are? You dumbasses. How dare you? How dare you tell me what you think you need? How dare you do your own research? This is what this guy is saying. People don't know what they need. They don't know what they want. You don't know what's good for you. You just let me tell you what's good for you.
intrathecal therapy is something that we use in dying cancer patients, for sure. It's very, very effective. But they're going to be dead in 6 months. And so we don't have to worry about whether it's going to work for 2 years. And we don't have to worry about spinal meningitis because, we know that they're dying. So it's not something that we otherwise use in pediatrics.
Is CRPS and or the Budapest criteria calls for once CRPS symptoms appear, they are continuous for life or until, quote, cured, end quote, or can they come and go all or in part forever or simply vanish and never appear again?
And there's a lot of questions in that question. So I'd say that the physical observation of stuff that goes on with CRPS diminishes during therapy over time. So the leg can remain cold and blue for a while, then it warms up as it's remobilized. And
Boosh says, WTF, awesome bedside manner. They're going to die anyway. Yeah.
we used
Great
the
bedside
allodynia
manner.
goes away slowly. So all those symptoms go away. And once we're done with the child and we think we've restored them, they can have some residual color changes. Those can stay for quite a while. That is to say, their leg will kind of turn weird colors sometimes. It'll be normal, and then it'll not be normal. But the rest of the symptoms and signs go away unless there's a recurrence, and then they come back.
Next question. Was I correct in hearing you say that one of the Budapest criteria relating to differences in body part temperatures was Maya did not have a colored or blue leg?
I'm not aware that she had a blue leg or color changes in her leg, or that she had a difference between right and left in the skin temperature of her leg.
This seems very drastic to meet the Budapest criteria. Cannot differences in body temperatures that are measured by basic gentle touch, by non-touch thermometers, or is, quote, discoloration, end quote, the criteria?
The criteria are go in categories: motor, vascular, skin, and the vascular criteria. You don't have to have them all, but it's color changes and temperature changes. You can definitely have one and not the other, but they usually go hand in hand because the color change means lack of blood flow. That's why the leg.
Do you remember when it used to be, oh, you get the best medical care in America ever? That's where everybody goes. That's where Saudi princes go. It's where everybody comes to get the best medical care. Not anymore. I'm going to be looking at hospitals in Kenya pretty soon. Examoon says hospitals in Kenya do more for their patients than Johns Hopkins. I don't doubt it. Our medical system is absurd. It's absurd.
Leg turns blue, and if there's not blood flow, there's not warm blood getting down into the leg, so the leg's going to feel cold. So they usually go hand in hand. The Budapest criteria, I think the question was, are they drastic or something like that? They're very, very useful, and they're not sacrosanct. They're not carved in stone, and sometimes children come in with very early CRPS, and they just haven't blossomed into the full picture. But you get the feeling that that's where they're going, and in fact it tends to be where they go.
Next question. Is it your view that if a drug or quote way of treatment end quote that is approved by the U.S. government is the only valid or allowed treatment?
Truthfully, almost nothing we do is FDA approved in children. Almost nothing. So no, I don't agree with that. And almost every drug that we ever give kids has not been approved for the use in children by the Food and Drug Administration. So we're using them, it's called off-label.
Next question. I believe past witnesses' testimony used the term titration. And with many drugs, more may be, let me start again. I believe past witnesses' testimony used the term titration. And with many drugs, more may be needed to have the same benefit over time. Is ketamine similar to other medications?
That's different than titration. So there's two things in that question. One is titration and one is tolerance. So tolerance is when you're using the same drug over time and you need to up the dose to get the same benefit. That happens with opioids, for example. It happens with insulin for diabetics. One dose works and over time they get resistant to it, so you have to give them more and more and more over time. Titration is something that you do, let's say, over minutes or hours or maybe days. You start a drug and you don't get the effect you want, so then you up the dose. So we do that with Neurontin, gabapentin, for example. We start at 100 milligrams a day, but our target is about 1,800 milligrams a day in your average teenager. If you don't give them 1,800 milligrams right off the bat, because number one, they'd have horrible side effects. Number two, you don't know what dose between 100 and 1,800 is going to work for them. So you just slowly ramp it up. It's called titration until you get the effect that you want.
Next question. You testified high-dose coma ketamine is not done in the United States. I'd assume it is not FDA approved. Is that yes, no, or?
It's not FDA approved, but that's not why it's not used.
Per other medical witnesses, is it, or it is approved in other countries throughout the world. Is that correct?
Mexico doesn't have an agency like the FDA, so stuff doesn't get approved or disapproved there. And that's why it's used so freely in Mexico, in Monterrey, by Dr. Cantu. The European Union does have a licensing body that's like the FDA that covers all our countries. I don't know what the status of ketamine is, but I'm pretty sure it's being used off-label there as a high dose. And we could use it here. It's not a law, the FDA approving or disapproving. Nobody's going to come and arrest us for doing that. We don't do it. The medical community doesn't use ketamine coma because it hasn't been shown to be effective and it's highly dangerous. As Cantu said, there's a 50% chance of Maya dying. Now, I think that's a little bit high, but still, I mean, it's dangerous. And we don't do it because it's dangerous, not because of anything the FDA says.
Next question. You stated that you do at times use ketamine in low doses to treat CRPS. Is that correct?
That's correct.
In terms I can better understand, low dose ketamine over time, is it like chlorine tablet floating in a pool to help control, make water better? Would not a period of high ketamine then be like a quote shock treatment, end quote, in a pool, which has its benefits as well?
Well, I've heard a lot of analogies to humans and medicine, but never a swimming pool before. As a general rule, more is not better. I mean, if you give 500 milligrams of penicillin to somebody, does that mean 2,000 milligrams is going to be better? And the answer is no. Why? Because 500 is enough, and the higher you go, the more toxicity you have, the more side effects you have, the more danger you have. So more is not better, and shock treatments we don't do that to the human body. It doesn't make sense.
We're on the last page. Only 4 more questions to go. In 2016, was CRPS a well understood ailment?
Yes.
In 2016, was CRPS a curable illness?
Well, I want to modify well understood. As I said, we don't know, and we didn't know in 2016, the exact cause of it. So there's a lot of science that's been done, a lot of biologists looking at it. We know there's changes in the spinal cord, there's changes in the nerves out in the body, there's inflammation. All these things are associated with CRPS. We don't know what actually causes it. We don't know why nobody gets it before the age of 10 or so. We don't know why it's 8 times more common in females than in males. We have no idea. So we don't understand it in that sense, but we definitely understand what it is. Like when we see it, we know it. And we know how to treat it with the available tools that we have, which are far from perfect, but this is what we got. Second question was?
In 2016, was CRPS a curable illness?
No, and it was not. I wouldn't call it curable. I would say it's something that goes into remission, hopefully for a long time in those patients who do have CRPS. for whatever reason. Is it luck? Is it genetics? I don't know. But I would hesitate to say that it's really curable, except possibly again for those 10-year-old girls. I've never seen it recur in them, and I've never heard of it from anybody else. But curable is a very strong word. I'd be hesitant to use it.
In 2023, is CRPS now a well understood ailment?
No.
It's not much better understood than it was in 2016, to be honest with you. It's a confusing disease.
So he admits they still don't understand it. So I don't know how they can rule it out for her.
Just don't know why people get it and what causes it, what the basic mechanisms are.
And the next and last question, in 2023, is there a medication or drug that will cure CRPS?
Oh, I wish there were. Nope.
Okay. Mr. Hunter, you're up next with any follow-ups.
Oh, my
Mr.
Lord.
Anderson, you're up next with any follow-ups.
Angel, welcome to the Fox Den. New member. Thank you. Cynthia sent $5. Says, you may want to go. Oh, I already got that one. Yep. Sorry, I went to the wrong one. Enchiladas unbreaded says, Popo, get your wallet out. Oh, I redid that one.
Almost every drug, right?
Horse welfare. I am
But most of the drugs.
catastrophically
No, not even mostly drugs. That took
and permanently disabled because an ER doctor who thought I shouldn't have a say in my diagnostic or treatment plan. I was correct. Oh, I am so sorry. What a terrible thing to have happened. But doctors are not always right.
Okay, well, why don't would it refresh your recollection to actually look at the discharge summary to see?
You guys, I don't think the jury hated him. I think they liked him and I think they believed him.
Next one. Okay, so I'm sorry, you're right. The beginning of the first one, the first page has the number 1 and 2. All right, Aquaphor.
not a drug.
Lenzaprel. Let's go. The next one. All right. Acetaminophen, albuterol, baclofen. That's prescription, is it not?
Yes, it is.
So is albuterol, is it not?
Yes.
All right. Cetirizine is, right?
She's obviously going to leave on asthma medications and allergy medications because she had asthma and allergy when she came in. So albuterol and cetirizine are allergy and asthma medications. So obviously, and the same is true for the Flovent, both nasal and inhalation. Those are asthma medications. Then there's several vitamins on here. There's the vitamin D. There's a laxative, Miralax. Like, show me a kid these days who's not on Miralax.
My kids aren't on Miralax.
It's a lot of medications, multivitamins. Those are not going to be taken away at this point.
You should not have your kid on Miralax,
review
by the way,
nutrition
unless
to
it's
decide if she needs those in the long term.
prescribed.
So what she's on for CRPS or
Feed
pain,
them more fruit and
is
vegetables.
pregabalin.
Yeah.
That's it.
No, what you told the jury.
I'm sorry,
did you
I can't get past that. He just said there's not a kid alive who's not on Miralax. If your kid is on Miralax, you have a problem, a dietary problem, unless there's some medical reason. But chronic constipation should not be an issue that any human being, especially a child, is having. And if it is a problem your kid has, more fruit, more vegetables, more vegetables, for crying out loud. America is gross with the kind of diets that we give our kids. You should be keeping your kid. You should be snacking. When you bring snacks places for kids, chop up some sweet peppers. Yeah, Onawal, more walking. Yeah, chop up green peppers, red peppers, carrots. Chop up vegetables, cucumbers. My babies loved cucumbers. You got to, instead of bringing bags of chips everywhere you go or cookies, bring vegetables. That's how you get them to like vegetables, by the way. That's what you offer them. Stop giving them potato chips, and then they won't have that problem. Yeah, my kids were never on Miralax. The chat is agreeing. Mrs. K. Griff says, my kid isn't on Miralax. Mama Ames, my kids were never on Miralax. Christina says, my daughter isn't. She eats too much fruit. Yeah, right. I mean, it's just apples, Lois. Yes. Bananas. Yes. A banana a day will solve this problem. For anybody who thinks their kid has to be on Miralax, just give them a banana instead. Kadada Smith, thanks for the super chat, says he never stops talking, blah, blah, blah. Answer the question, yes or no. He's annoying. I agree. Popo,
that because of the
Popo, did you see that? There's another $20 chat. You owe me 20 more.
care and treatment
We're
of
going
Johns
up to
Hopkins
250,
over this
right?
3-month period, that her asthma was much better as well. Did you not?
No, I didn't see that.
Okay. But it looks to me like there are at least 6 different prescription drugs that she was checked out with, and over 14 different substances listed. Do you agree with that?
Not over 14. There's 14 exactly listed. Some are drugs and some are not. And yeah, so 14, some are drugs, some are not. And the pain medications that she was taking when she came in are not on the list.
You were telling us that the ketamine coma is dangerous, highly dangerous. Do you know that over the past 10 years, Dr. Cantu has been performing these, that there has never been a single death or major injury from them?
Well, Mr. Anderson, he's doing this in Monterrey, Mexico. There's no report of a single death or a single injury, but how do we really know that?
And so he's just stowing the bodies in the backyard or something? I mean,
I'm
why
not
wouldn't there
saying
be?
that, sir. I'm just saying we don't really know. There's no data.
I will sustain the argumentative objection.
Oh, what's wrong? Then as to Dr. Hanna, are you aware he has treated over 18,000 patients with his infusions, some up over 2,000 milligrams over 4 hours?
Objection, Your Honor, lack of foundation and proper location.
Overruled.
Well, you're testifying all about these men. I would like to know if you're aware of that.
18,000 patients
Yep.
in his practice?
Yep.
I don't believe it.
Okay. All right. Let's just say if he comes in and testifies to that, that's how many. Wouldn't you expect out of that many patients that at some point, if it was so dangerous, what he was doing, his titration, there would be at least one or two bad results?
Objection, argumentative.
Sustained on that one.
What, if any, bad results have you discovered in all of your intensive examination of these facts? What bad results have you seen from either Dr. Cantu's ketamine coma or from Dr. Hanna's infusions?
Objection, Your Honor, lack of foundation and argumentative.
Overruled. You can answer.
In Dr. Cantu's hands, Maya developed a multimicrobial pneumonia requiring antibiotics and could have been a life-threatening pneumonia. She also may have aspirated. There was one time when she vomited with the endotracheal tube in, and there's notation in one of Beata's emails that the nurses had to jump on her, and there was suctioning the vomit out of her mouth and suctioning her tracheal tube, that breathing tube, to clear material out of that. That might have been the source of her pneumonia for all I know. But a multimicrobial, which means several different kinds of germs, bacteria, a multimicrobial pneumonia is not treatable. It's very dangerous. So it's hard to say. I mean, I can't say that she came to no harm. She did come to harm. As far as did you ask me about Dr. Hanna's treatment of her? He was giving her humongous doses of ketamine. She was losing weight. She had abdominal pain. She wound up in the hospital. I can't say that there was no harm from that.
No, I was asking you about statistics, whether you have any statistics or reported cases. Let's leave your view of what happened with Maya aside. Any reported cases or statistics from either physician indicating the procedures they were using were causing injury or death?
Lack of foundation, argumentative, Your Honor. Be honest with you.
You can answer that. Overruled.
Are you asking me, did Cantu and Hanna report their problems?
I'm asking you whether any patients came forward, or the government agencies came forward, whether Dr. Cantu himself came forward, whether Dr. Hanna himself came forward, whether their family, friends, anybody else ever came forward with any information you've been able to find that either one of these procedures caused a serious injury or death.
I'm going to overrule the objection. You can answer it. Then let's move on, Mr. Anderson.
Well, I have not. I'm not a detective. I did not go after Cantu and Hanna and look to see if in their practices they had harmed anybody.
You didn't go after Cantu. Okay, so
how would I know the answer to that question? I haven't gone through the files and police records or lawsuits. I haven't gone through the databases to see if Hannah's ever been sued before, or if anybody has raised a claim or made a claim to the medical board. All these things are possible. I have no idea. Probably not. I mean, probably it's all under the radar.
Mm-hmm. This is called the suicide disease, is it not?
No, I've never heard that term.
You've never heard of CRPS being called the suicide disease?
Never heard that.
All right. Have you ever had any patients commit suicide as a result of CRPS?
When we did our survey, we found one patient who had actually her parents filled out the survey. She was 30 years old and she had committed suicide. But when she left our practice, she was in remission, and then she overdosed on OxyContin. Where she got the OxyContin, from whom, I have no idea. But it was an OxyContin overdose. I'm not sure if it was a suicide or not.
Were there actually 3 others? Did you have 3 other suicides?
No.
Okay. So ketamine is FDA approved, and it is true, is it not, that there is no FDA upper limit to its use?
Well, it's approved as a general anesthetic. Yes.
Right. And it's approved to be titrated to the anesthesiologist's judgment of effect, right?
to perform general anesthesia and surgery. It's not approved for neuropathic pain, complex regional pain syndrome, etc.
Well, right now it says it's as an orphan drug, is it not?
Well, as I said earlier, there's nothing wrong with using it off-label without FDA approval. The question was, is it approved? Yes, it's approved for general anesthesia, but not for
Oh no, I
idea
just
is
missed
it-
all of that. I'm sorry, guys. I'm sorry. I had to take a phone call. It was from school. Hangry Fox, his math teacher was on the phone. We've got some math to do. I'm sorry, but I have to go back. I missed all of that. So we're going to watch it again, okay? I'm sorry. I was on the phone for however long that was. And it seemed like I was watching his body language. He was getting very defensive. So now I need to know. I need to know. I'm really sorry. I'm sorry, but I have to go back.
What happened with Maya aside? Any reported cases or
No, I still didn't hear that.
several different kinds of germs, bacteria.
No, still didn't. I back further. Sorry, guys.
Sustained on that one.
What?
Patients,
Yep.
in this practice,
Yep.
I don't believe it.
Okay.
Full death or single injury, but how do we really know?
Nope.
Different prescription drugs that she was. Well, the jury
Okay,
did
here,
not
I
that
heard
because
this.
of the care and treatment of Johns Hopkins over this 3 months.
Okay, I heard this.
But it looks to me checked out with over 14 different substances
Yep,
listed.
heard this. It was
No
right
drugs?
then.
Some are drugs, some are not.
Is dangerous, highly dangerous. Do you know or major injury from them?
Well, Mr. Anderson, he's doing this in Monterrey, Mexico. There's no report of a single death or a single injury, but how do we really know that?
And so he's just stowing the bodies in the backyard or something. I mean,
He's just stowing the bodies in the backyard.
why wouldn't there
Yes,
be?
sir. I'm just saying, we don't really know. There's no data.
I will sustain the argumentative.
You know, this is
Objection.
highly racist. What do you think? Just because it's going on in Mexico, that it automatically makes it a bad place and bad care because it's Mexico? I'm sorry, but that seems a little racist to me. Racist.
I'll draw. Then as to
He's
Dr.
laughing.
Dr. Hanna, are you aware he has treated over 18,000 patients with his infusions, some up over 2,000 milligrams over 4 hours?
Objection, Your Honor, lack of foundation and problem patient.
Overruled.
Well,
I
I'm
would-
testifying all about these men. I would like to know if you're aware of that.
18,000 patients
Yep.
in this practice?
Yep.
I don't believe it.
Okay. All right. Let's just say if he comes in and testifies to that, that's how many. Wouldn't you expect out of that many patients that at some point, if it was so dangerous what he was doing, his titration, there would be at least 1 or 2 bad results?
Objection, argumentative.
Sustained on that one.
What, if any, bad results have you discovered in all of your intensive examination of these facts? What bad results have you seen from either Dr. Cantu's ketamine coma or from Dr. Hanna's infusions?
Objection, Your Honor, lack of foundation.
Oh, he just
and
rolled his
argumentative.
eyes.
Overruled. You can answer.
In
Did
Dr.
you see
Kent-
that?
Objection, Your Honor, lack-
Look at
Ketamine
that.
coma or from Dr. Hanna's infusions?
Eye roll.
Objection, Your
Look at him.
Honor, lack of foundation and argumentative.
Overruled. You can answer.
In Dr. Cantu's hands, Maya developed a multimicrobial pneumonia requiring antibiotics, and could have been a life-threatening pneumonia. She also may have aspirated. There was one time when she vomited with the endotracheal tube in, and there's notation in one of Beata's emails that the nurses had to jump on her, and there was suctioning the vomit out of her mouth and suctioning her tracheal tube, breathing tube, to clear material out of that. That might have been the source of pneumonia for all I know. But a multimicrobial, which means several different kinds of germs, bacteria, a multimicrobial pneumonia is not treatable. It's very dangerous. So it's hard to say. I mean, I can't say that she came to no harm. She did come to harm. As far as did you ask me about Dr. Hanna's treatment of her? He was giving her humongous doses of ketamine. She was losing weight. She had abdominal pain. She wound up in the hospital. I can't say that there was no harm from that.
No, I was asking you about statistics, whether you have any statistics or reported cases. Let's leave your view of what happened with Maya aside.
All right, well, then he shouldn't have let him go on and on about that. He should have shut him down and said, "You're not answering my question." Objection non-responsive. My question was about statistics.
Any reported cases or statistics from either physician indicating the procedures they were using were causing injury or death?
Lack of foundation, argumentative, Your Honor. Be honest with you.
You can answer that. Overruled.
Are you asking me, did Cantu and Hannah report their problems?
I'm asking you whether any patients came forward, whether government agencies came forward, whether Dr. Cantu himself came forward, whether Dr. Hannah himself came forward, whether their family, friends, anybody else ever came forward with any information you've been able to find that either one of these procedures caused a serious injury or death.
If I were Anderson, I would ask him, so doctor, are you telling me that I should never go to a brown doctor again? Because it sounds like you're saying brown doctors aren't to be trusted because they're not good doctors.
Overrule the objection. You can answer it, then let's move on, Mr. Anderson.
Well, I have not. I'm not a detective. I did not go after Cantu and Hannah and look to see if in their practices they had harmed anybody.
You didn't go after Cantu? Okay, so
how would I know the answer to that question? I haven't gone through the files and police records or lawsuits. I haven't gone through the databases to see if Hannah's ever been sued before, or if anybody has raised a claim or made a claim to the medical board. All these things are possible. I have no idea. Probably not. I mean, probably it's all under the radar.
This is called the suicide disease, is it not?
No, I've never heard that term.
You've never heard of CRPS being called the suicide disease?
Never heard that.
All right. Have you ever had any patients commit suicide as a result of CRPS?
When we did our survey, we found one patient who had actually her parents filled out the survey. She was 30 years old and she had committed suicide. But when she left our practice, she was in remission, and then she overdosed on OxyContin. Where she got the OxyContin, from whom, I have no idea. But it was an OxyContin overdose. Not sure if it was a suicide or not.
Were there actually 3 others? Did you have 3?
She was trying to treat the pain that he didn't treat, most likely.
The other suicides?
No.
Okay. So ketamine is FDA approved, and it is true, is it not, that there is no FDA upper limit to its use?
Well, it's approved as a general anesthetic. Yes.
Right. And it's approved to be titrated to the anesthesiologist's judgment of effect, right?
To perform general anesthesia and surgery. It's not approved for neuropathic pain, complex regional pain syndrome, etc.
Well, right now it says it's as an orphan drug, is it not?
Well, as I said earlier, there's nothing wrong with using it off-label without FDA approval. The question was, is it approved? Yes, it's approved for general anesthesia, but not for anything else.
But the idea is it titrates an experienced anesthesiologist using it for whatever purpose they've got, treatment of pain, or I guess during the course of a surgery. It's the anesthesiologist's judgment to titrate to effect, is it not?
No.
So you just press a magic button and you know that amount is the right amount under each circumstance?
Sustained.
Well, would you agree with me that
I'm tired of this guy. I feel like I've seen him all day. Anderson, can you wrap this up?
the judgment of the anesthesiologist is very important in determining the amount of a particular anesthetic given during procedure?
During an operation? Yes.
And the goal is to achieve efficacy, that is, a positive response to whatever medication you're using.
During surgery,
Correct?
the goal is to have the patient unconscious.
Right. So now, in Dr. Cantu's case, you were talking about harm to, I guess, Maya, and you said it was from an infection, right?
Mhm.
That was not caused by the ketamine. That was caused by the fact of intubation, wasn't it?
No, absolutely not.
Wasn't it treated within a matter of 4 or 5? I thought you just did.
No. The intubation was done to protect her airway so that she wouldn't get pneumonia. And she would be able to they could breathe for her. The intubation was necessary. That's why we do it in the operating room. That's not what caused the pneumonia.
Perhaps I misspoke. The ketamine as a chemical, a drug in her body, did not prompt the development of bacteria. It was the fact that there was a tube down her throat that produced this.
No.
True?
No. That's not how it works. The ketamine rendered her unable to breathe effectively and unable to protect her airway from aspiration. Therefore, the tube was put in to protect her airway. So in that sense, the ketamine was not the immediate cause of her pneumonia, but it was the cause because without the ketamine, she wouldn't have needed the tube, she wouldn't have needed the ventilator, and she wouldn't have developed pneumonia.
How many patients have you intubated in your career?
Many thousands.
Thousands of them. And through the course of your intubations, you have from time to time seen this exact same occurrence. That is the development of a bacterial infection.
Bacterial infections occur in intensive care patients who are on ventilators because they cannot cough effectively and clear secretions.
So the fact of an intubation in and of itself is an accepted medical procedure, true?
True.
And in this instance, this infection was resolved within less than 18 hours through the use of broad-based antibiotics. Don't the records reveal that?
I don't have Dr. Cantu records. I don't
Okay.
think they're in the record here.
You were going on Beata Kowalski's.
Can the witness finish his answer?
Sure.
We don't have medical records. We can't say that it was within 18 hours. I don't know her fever curve. I don't know what her sputum was like. That was suctioned up by the nurses. I don't know if you ever repeated the cultures. I have no idea.
So you're not aware of the testimony of Dr. Cantu here about that?
What I'm saying is I don't have the records to show that she resolved it within 18 hours. It's possible. I'm
Okay.
just saying the record doesn't reflect that.
You also were talking about withdrawal symptoms from ketamine. And is it true that ketamine does not directly affect the opioid sensors in the brain?
That's true.
And through the course of this, the one thing I recognize is you said, as part of withdrawal symptoms, you would expect someone to be wired, right?
Ketamine withdrawal?
Yes.
Benzodiazepine withdrawal, morphine withdrawal? Yeah.
Yeah, but we're specifically talking about.
Wired is it's not a good term. I regret using that. Let's say anxious and agitated.
All right. What objective signs accompany agitation and what was your other term?
I said anxious.
Anxious and agitation, is that right?
Yes.
Okay. What physiological signs of agitation and anxiety will you have? Would you expect?
Physiological signs? By what do you mean physiological?
Well, would you expect an elevated blood pressure?
Possibly.
Elevated heart rate?
Probably.
Would you expect in the medical records themselves some statement by the patient of being anxious or being agitated?
Perhaps. Children don't generally say I'm anxious.
Well,
you can see their agitation. They don't need to tell you that.
Nowhere in any of these records did you see any indication of an increase in blood pressure, an increase in heart rate, and a statement of any type that the child felt agitation.
Children don't feel agitated, they act agitated, and people observe that agitation. She certainly was agitated. And the fact that there aren't vital signs that you might expect to go along with that opens a whole other can of worms. I don't know if you want to go there, but probably. I'm not a psychiatrist, so I shouldn't.
She was agitated for a grand total of about 5 hours, was she not? On October 7th.
And then she went to sleep, right?
5 hours, right?
Meaning what?
And they gave her an antipsychotic either that night or the next, right?
That's right.
And they kept her on an antipsychotic for most of her stay, did they not?
No, I don't think it was most of her stay.
At least for the next 4 weeks.
That wasn't most of her stay, but they did keep her on for a period of time to control the behavior.
Anything else, Mr. Anderson?
By the court's question, I do not believe so.
You're free to ask whatever questions you want. Anything further, Mr. Hunter?
No, Your Honor.
Members of the jury, are there any more questions?
Oh, they're totally going to have more questions, but I'm not a big fan of their questions for him. I don't think that they have been very hard on him at all. I bet the defense is feeling pretty good about this witness. I think he did what he was supposed to do. He put a whole lot of doubt. Oh, they didn't have any more questions for him. That was it. Who's this next witness?
Stand here, face forward, and raise your right hand.
You solemnly swear to affirm the testimony you're about to give will be the truth, the whole truth, and
Yeah. Oh, more dark hair.
You may proceed.
Thank you, Your Honor. Good afternoon.
She looks exactly like Dr. Pepper.
If you could introduce yourself to the jury, please. And Dr.
Paula
Dees, what is
Dees.
your profession?
So what is the deal with these women? They look the same. Dr. Dees and Dr. Peppa Sanchez look exactly the same.
I am a pediatric hospitalist at Johns Hopkins All Children's Hospital.
What is a pediatric hospitalist?
A hospitalist is a pediatrician that specializes.
Let me remind you what Dr. Peppa looks like. Let's see if we can bring up the Munchie Bunch here. There she is down there in the right corner. So do you see it? Do you see it? It's like the same person. Are we sure that this isn't Dr. Peppa in a Dr. D's disguise? I don't want to hear any simping.
Hospitalized children, so outside of the
No
ICU, but on
simping.
the general medical service.
So let's go back a little bit, if you don't mind. Where did you get your medical degree?
My medical degree I obtained at Florida State College of Medicine.
And what
College
did
of
you do after
Medicine.
obtaining your medical degree?
I attended pediatric residency at the University of South Florida, training both at Tampa General Hospital and at All Children's Hospital. And then after graduating residency, I stayed on and was hired as an attending physician at Johns Hopkins All Children's Hospital, and I have been there for the entirety of my career since.
During your training or your
Welcome
residency,
to the Fox
did you receive
Den
any
line by
awards
the
or
sea.
I did. I would have to refer to my CV for a complete list, but during medical school, I was inducted into the Alpha Omega Alpha Honor Society, which recognizes top academic performers in medical school. I was also inducted into the Gold Humanism Honor Society, both in medical school and residency.
Humanism.
That honor society is a peer-nominated process.
The Humanism Society? That sounds like witchcraft, lady. Is it time to bring in a duck yet? Should we bring in the duck?
Identifying physicians that are felt to be kind of exemplary, empathetic, and compassionate physicians.
Are you board certified?
I am, both in pediatrics and have my subspecialty certification in pediatric hospital medicine.
And you may have said it, I apologize. How long have you been with All Children's Hospital?
I did complete my residency training and did training at All Children's. I have been an attending physician at Johns Hopkins All Children since June of 2011. So just had my 12-year anniversary as an attending, but if you include the 3 years of residency training, I've been there for almost 15 years now.
And I think you touched on it earlier, but if you could explain to the jury, what does a hospitalist do?
So a hospitalist is a pediatrician that takes care of patients that are that require hospitalization. So their medical condition is severe enough to require hospitalization and not just be managed by their pediatrician as an outpatient or in the clinic setting. So if a patient comes in and needs to stay overnight for whatever condition, we will continue to evaluate them.
Roland says, I bet she helped kidnap Jesus. Like, totally.
And treat them throughout the course of their hospitalization. We often work with other subspecialists and consultants. We have a multidisciplinary team at our disposal here at the hospital. We kind of think of ourselves as like a quarterback, so to speak. So we are typically in charge of the case in most scenarios, although we do consult on other cases. But we'll typically then put together a team of specialists, whether we also include things like physical therapy, speech therapy, et cetera, and kind of coordinate the care between all those subspecialists and serve as kind of the main attending physician for the care.
Did you have a chance to care for Maya Kowalski during her hospitalization at All Children's between October 7th, 2016 until she was discharged in January of 2017?
I did.
Okay. I'm going to walk you through a couple of your
I
encounters
did.
and see if we can,
I did. I
get an
did.
idea of what you provided care for. We're going to start with Joint Exhibit 1001-0425.
She is sped up a little bit.
Okay, and if you can go in 1.25. It starts with hospitalist. So, doctor, we see two names here after the word hospitalist.
Yes.
One is yours, and then there's someone named Patrick Del Santo. Can you explain who that is?
Patrick was one of our residents at the time. We are a teaching service at Johns Hopkins All Children's Hospital, so we can typically, as part of our hospital medicine team.
Ugh, I can't do it. I can't listen to this anymore. I've been sitting here for 4 hours. I'm going to have to come back later because I need to go take care of kids and dinner and all kinds of stuff, and I can't listen to this for the next 2 hours. So what I'm going to do is I'm going to listen to it while yes, queen. I'm going to listen to it while I make dinner and whatever. And if there's anything important, maybe I'll come back later and do it. But I can't. Courtney says, I'm late. Megan, first witness, you're faking comment. You're so immature. I know. I can't help it. Yeah, remember to do your squats. In fact, we've been sitting here for so long, it's time to do squats again. So instead of playing the regular outro, I'm going to leave you with the squats, okay? Make sure to follow me at meganfox.locals.com. That way you will know when I am going live again. So if I decide to come back on tonight, you'll know, you'll get the notification there. And I promise it'll be a really good time. Why do people talk like this? So do your squats, and I'll see you later. See ya.
You impose fatness on you. You did it by going, oh, I want the butter on the popcorn. Oh, I want the butter on the ice cream. Oh, I want the butter on the sandwich. Oh, I want the butter on the salad. Stop eating butter. Can you just get up, walk 1 mile? Do squats! Walk farther. And if you can't walk, crawl, roll, get dragged by a goddamn forklift. Whatever is wrong with you, just move. Ever. Get off the chair. Get off the couch. No one is coming to service you while you sink into that furniture, while you become one with the pleather your poor ass got on that Walmart couch. Can you try not floating into sadness? Stop eating, stop drinking, start walking, start doing anything that you haven't been doing, you fat piece of shit.